well known to us, and to be like one of them was my teacher during my post-graduation days, Dr. Mallikarjuna. We used to read his notes, even though we are in a different hospital. We used to read his notes and study. So that's the relationship we have, and it's a great privilege to have them with us. I invite our president, Dr. Shamsu Begum, to welcome the gathering.
Respected our ISA National President, Dr. Venkatagiri. I'm not sure whether our National Secretary is also there. And also I respected ISA National Secretary, Dr. Naveen Malhotra, all other senior respected ISA leaders and other ISA members, dear friends and colleagues, also our academic program coordinators, Dr. Rajesh, Dr. Vinil, and Vijesh, Paul Raphael. I welcome all of you to our third academic program, ISA academic meeting today. Today we will have three main topics. That is, one is by Dr. Manjunath, Professor and HOD Anesthesiology of Mysore. He will be talking on chest X-rays. And then the second person is Dr. Professor Mallikarjuna, Professor and HOD from Sullia Medical College. He will be talking on hypertension and anesthesiology. I welcome both of the professors to this academic program. And the next session in the PG corner, it will be from the two PGs from our Government Medical College, Thrissur. They are Dr. Irfana and Dr. Kannan. I also welcome both of you to this program. And also at the same time, I express our deep condolences and prayers for on the unexpected loss of our editor-in-chief of IJA and also a senior of ISA, Dr. Lalit Mahadirga, on 17th of February. And I express all our prayers for him. And with that, we will be passing on to our academic program. And also now I invite our ISA National President, Dr. Venkatagiri, to inaugurate this program.
President Dr. Shamsa, Secretary Paul, past President, past Secretary, faculties, and my friends, both Mallikarjun and Mysore HOD Manjunath, and Karnataka. He is the President of ISA Karnataka also. And friends, continuing with last year, this year also we are having this academic program with eminent faculties, and it will get more and more popularity, and more PGs will attend. And our coordinators, Rajesh and Vijesh, are making all efforts to make it more attractive. The PG papers, which was more attractive last time also, I felt that there is PGs will be more interested in doing one or two drugs equipment or so. So I wish all the best. Hope that it will continue well, and PGs will take benefit of this thing. And better they attend live than afterwards seeing in the YouTube and all, because YouTube is too many people see afterwards, because live means they can discuss, and the charm of seeing live is more than later watching the YouTube. Okay, over to you, Rajesh, for the proceedings. Thank you.
Thank you, sir. And it's my pleasure to welcome Dr. H.G. Manjunath, Professor and HOD, Department of Anesthesiology, Government Medical College, Mysore, for today's program. Today, he will be discussing chest X-ray. We don't need any introduction of Manjunath sir, because we know him very well. Last time, I think it's 3 weeks before, during the last class, he presented a lecture on ECG, and it was a very good lecture. So today we are expecting a very good lecture from him. So over to you, sir. Manjunath sir.
Sir, you have to unmute. Mute agide nevu.
Okay.
Yeah.
One second, sir. Just try now, sir.
Yeah. Now got it. Binil, now I got it.
Yeah. Thank you, sir. And you are audible. You can share your slide.
Yeah. Okay, can you see the first one?
No, it's not visible till now.
No, sir.
Yeah, 1 minute. Share screen. Now?
Yeah, it's coming, sir.
Yeah, it started sharing. Yeah, it has come. You
Yeah.
have to put in slideshow. Okay, sir.
Yes, sir. Okay, sir.
Yeah, yes.
Yeah, okay, sir. Is it audible? Okay, everything is okay, sir. Okay. Good evening, dear all. Dear National President, Dr. Venkatagiri, sir, Paul, Rafael, sir, Shamshad Begum, Binil, Nazar, sir, and Dr. Rajesh. And good evening, each and everyone. Good evening, the office bearers of ISA Kerala branch, and my dear postgraduates and other members. Today, we're going to speak on chest X-ray interpretations. So thank you very much for giving me the opportunity, ISA Kerala. And I'm actually a part of Kerala right now. Since many years, I'm participating in this. Thank you, each and everyone. I know them personally also, and I worked in Kerala also. So I'm happy to be a part of this ISA Kerala. So today we'll go on to speak on chest X-ray interpretation. So we're going to speak on only technical aspects and some of the important case scenarios we're going to present to you, because the upcoming DNB examination on 24th, I think it will be helpful for all the DNB exam going postgraduates. Greetings from Mysore Medical College and Research Institute, Mysore Medical College, where I am working as a professor at the department for the past 7 years. So we'll go straight away, go to the introduction of chest X-ray. So this pre-operative assessment, as you all know, is an integral part of our anesthetic management. So whatever the things, whatever the any cases, you have to go and 1 day before, and you have to assess the patient, and you have to make a fitness and plan for the anesthetic management. So this pre-anesthetic evaluation cannot be overlooked, and it should be is a part of X-rays have been a part of investigation in the pre-operative cases, pre-operative, as these X-rays gives a lot of information regarding the patient's conditions of the patients. So disease of cardiorespiratory system and airway problems are more important to the anesthesiologist, and chest X-rays and X-rays form the chest X-rays and neck X-rays they form the part of very important part of pre-operative assessment. So I will going to speak on this chest X-rays. These are the very important as far as getting a mass is concerned. If you go serially, if you go on looking at these things, go on looking at these X-rays, you're going to be able to get mass very easily. So chest X-ray is nothing but it's just a black and white one film, where you have to have a technical quality as well as the scanning. The two things are very, very, very important. Technical scanning of this film has to be done, and also the scanning of the film has to be done before going in for the actual assessment, actual assessment of the disease itself, or actual assessment of the film itself. So how to go about systematically? So for that, you need to have a technical quality. I'm going to tell you in the slowly, I'm going to tell you another 30 minutes to so. I'm going to tell you the another 15 minutes I'll take it for a technical quality, and so I'm going in for just a planning. And after that, I'll go for a case scenario base. I'm going to put some case scenarios, and I'm going to tell you the typical chest X-ray, which we're going to keep in the X-rays, in the examinations. First and foremost, what are the technical quality means? Should know in terms of label, projection, side, rotation, exposure and penetration, timing in relation to the respiration, adequacy of the film. So why you want to know this label, projection, everything technical quality means? So these, if you don't know these things, the interpretation may be somewhat difficult. Even a normal interpretation, normal chest X-ray, you may interpret in a different way. So you need to know this label, projection, side, everything. So as a technical quality of the film. So before going on to the chest X-ray itself, you should know what is meant by radiolucent, radio opaque, and radio density. The term, these three densities should be known to each and everyone. What do you mean by radio density? Radio density is nothing but it is used to describe how much radiation an organ can absorb. Okay, so air within the lungs hardly absorbs any X-rays, and therefore lungs appear blocked. It's called radiolucent. Okay, so then the radio density of the bones is much higher than the air or soft tissues, but it is less than metals. So that is, it appears as white. I think I kept it then. The esophagus, the major blood vessels, and other soft tissues have the same radio density, and thus it cannot be differentiated in a plain X-rays. These are the three important things which as far as the X-rays. But before going on to that X-ray, you should know it in your mind. So next, coming to the technical quality of the film. So technical quality of the film will going to affect your interpretations. For this, these are the two classical example of how it will going to appear. This is the normal chest X-ray film taken as a AP view and PA view. Just look at these two figures. If you look at the AP view, you will going to see that. So this is you're going to see that the heart border appears to be nearly bigger, but it is there is no pathology involved in this. But PA view, if you look at the PAO, heart values, heart shadows appear normal. Okay, and at the same time, other things looks very distorted. So the technical quality of the film is very, very important as far as the AP or PA view is concerned. You should be very careful. Whenever the AP view is given, you have to define the heart. You have to see the heart properly. Otherwise, you will end up in doing the patient is having a cardiomegaly. So you should be very careful by looking at the AP and lateral view. So now, how will you going to differentiate between the AP and lateral view? So whenever the patient is going in for AP and lateral view, so that normally the PA view, the X-ray, so X-ray beam and X-ray machines will be there, and X-ray beam will be put from the X-ray machine, and a film will be, two things are there, and the three patients. So in between the patients, so X-ray beam will be fired towards the patient, and the X-ray film will be kept. In PA view, the X-ray beam will be from the behind the patient. X-ray film will be kept in front of the patients. This is called a PA view of the patients. Okay, this is the one classical example. The chest, I think I told in a different way, I think. Yes. The AP view, the projection is, this is called a projection. It's called a projection. Projection is AP or PA view. The projection is defined by direction of the X-ray beam in relation to the patient. In AP X-ray, the X-ray machine is front of the patient. So I'm very sorry. The AP, don't confuse it with the X-ray machine is in front of the patient and X-ray film at the back. This is AP. The PA film, the beam is fired from the behind, and the film is beam is fired from the behind, and the film is kept in front of the patient. I hope I am clear. So I should be very careful. AP and PA view. So AP view, the beam, the X-ray machine is in the front of the patient, and the film is kept on the back of the patient. I hope clear. And exactly reverse, the PA view will be there. Okay. So will you go to identify AP and PA view? The PA view is the standard PA view, and AP will be going in for emergency surgeries. Whenever there is an emergency or the patient is bedridden, you will going to have a AP. Usually AP will be written on the X-ray film, AP, like that it will going to be written. So how will you going to identify these things? So in a AP film, the scapula, look at the scapula. That scapula will be easily overlay the thorax scapula, and heart looks very broader. Okay, this is the two things. The scapula will be overlying the thorax, and heart looks broader, and the basal form of the lungs little bit haziness. Okay, it's just a PA view. So the scapulae are no longer overlying the thorax. Okay, heart shadow appears normal. These are the two important things. One thing is there, the PA view is the standard chest X-ray view, and it will not be written in the PA like this, like that view will not be written. AP will be written on the AP itself. It will go to write AP. So that means to say that this is an emergency X-ray which will be taken in a supine patients or the patient who has confined to the confined to the bed. It will go. It's easy for us to take an X-ray because patient is not moving. So the next is the inspiration. This also will going to have a effect on the technical quality of the effect. If you don't take it in a full inspiration, you will end up in interpretation is a different way. So for example, these two, this is the full inspiration. This is the patient is taken full inspiration. This is the one, this is the right side one is taken at a full inspiration, and with a poor inspiratory effort, this is the one which will taken as a poor inspiratory effort. Look at these two figures. One is that this basal haziness will be there at the same time. Second thing is, look at the heart shadow. Here also look at the heart shadow. You will going to end up as this is a cardiomegaly. So the inspiration should be very good in this patient. If you take a full inspiration, you can able to identify the so what are the methods of reading a chest X-ray? The reading chest X-ray can be center to periphery or from periphery to there are different methods are there. I will going to tell you in detail regarding that. So before going into the reading of the X-ray, so this orbitally will going to divide into the upper zone, middle zone, and lower zone of the lung fields. And the upper zone will be from second rib onwards, upwards from the secondary, so above the second rib, from second rib, anterior border of the second rib, from second rib to fourth rib, anterior border of the fourth rib, and fourth rib up to the level of the diaphragm, we're going to have upper, middle zone, and lower zone. And similarly, we're going to have the superior mediastinum and the inferior mediastinum. So you're going to have a lateral chest X-ray also. In the lateral chest X-ray, you can able to divide the mediastinum. This is the mediastinum. This is the mediastinum. We're going to show you. We're going to mark this structures visibly. Later, we're going to find out. This is as a PA view or AP view. We're going to have a superior and inferior mediastinum where the heart will be there. And in a lateral chest, we're going to divide into anterior mediastinum or a posterior mediastinum and a middle mediastinum. We're going to have that. Now coming on to the, so how will you go to scan the X-ray? So first, before going on to the scan the X-ray, look at the date of the date which is entered in there, and look at the patient name and age. These three things should be done. And mentally scan the film thoroughly before going on to make a diagnosis. Suddenly don't stop. Whenever you find a lesion, don't stop at that point. Otherwise, you will be so engrossed so that you're going to find out, and the next thing you will going to be forgotten. So first, you thoroughly scan the whole X-ray. Later, you can able to find out. So before going on to that, first and foremost thing is look at the lung fields. Okay, so when you look at the lung fields, it should be both the lungs are visible and equal transradiancy, and should not be any whiter or darker film. So I told you earlier. So both should be, volume should be equal. Both the sizes, density should be equal density transradiancy, and it should be volume. Everything should be equal, both sides, right side and left side. That is the important thing. So next, try to identify horizontal fissure. This is the horizontal fissure. You see, I just marked it. So I'm going to increase to make it a bigger one. Yeah. Yes. I think I'm so first and foremost things, try to identify horizontal fissure. This horizontal fissure runs from the hilum to the sixth rib in the anterior in the axillary line. So it is very difficult to make out, but still you can able to make out very faintly from the hilum. This is the hilum. I'm going to tell you what is the hilum. So hilum is nothing but it is the entry of the midpoint of the entry of the lungs, where this the vessels, nerves, everything will go to entry and exit from the lungs. This is nothing but a hilum. Okay, so that's why it's called hilum. Okay, this is from the hilum up to the sixth rib in the axillary line. You have to identify the oblate. This is the horizontal fissure. Look for any other discrete or generalized shadows. The white lung field. Remember, the abnormalities of lung field can represent pathology from anywhere. Okay. The next, they can look at the hilum. Hilum is nothing but it is, as I said earlier, it is a root. It is nothing but a root. Pulmonary hilum refers to the regions of the lung where the blood vessels, the arteries, veins, and nerves, and enter and exit the lungs. This is nothing but a hilums. So the right hilum little bit, so right hilum should be higher than the left hilum. So left hilum should be higher than the right hilum. The difference is not much than 1 inch or 2.5 centimeter. It should not be more than that. And it is a concave in shape, and it should be a concave shape. Compare the shape and density of the hilum before going on to the any other pathology. Then look at the heart shadow. Look at the heart shadow should be normal in size and shape, and density should be there. And diameter of the diameter should be the maximal diameter of the heart should be lesser than the transthoracic diameter. That I will going to tell you how to measure this later part of the. Check the rest of the mediastinum. this degree of the mediastinum, the edge of the media should be clear through though some fuzziness is acceptable at the angle between the heart and the diaphragm, hypophysis and the right lung. There are some fuzziness is going to be it is there, so that should be allowed. But if there is any fuzzy edge to any other parts of the mediastinum, suggests a problem with the neighboring lung. So collapse, or if there is any collapse or consolidation, so that there is a problem in this. So I'm going to tell you what are the signs of this. So just look at the visceral pleura, parietal pleura. These are the oblique fissure. This is the oblique fissure what I have drawn here, and this is the diaphragm. Both are diaphragm here. So this is the both the diaphragm, and this is the costophrenic angle. This is the costophrenic angle. These are the cardiophrenic angles. Okay, this is the heart shadow, and this is the mediastinum. This whole thing will be represents the mediastinum. I hope I am clear. This whole thing will be mediastinum. This is the heart shadow, borders of the heart. I will go and tell you what are the borders of the heart. So this, just imagine these things. This is the lung. Okay. Next comes this figure. Sorry, go back to the slides. Yeah. The blood vessels. The blood vessels create opaque branching pattern visible through the darker lung parenchyma. That it should be noted that these are the blood vessels. They gradually taper towards the periphery. So you should just look at these blood vessels. They create. This should be there in the normal lung parenchyma, and you have to observe it and you have to appreciate this thing. Next, we will go to cardiac shadow. Okay, just 1 minute. Hold on. Just I'll get a. Okay, this is a cardiac shadow. So it is later it. This is the thoracic. This is the left common carotid artery. This is the arch of aorta. Okay, this is the left atrium. This is the left ventricle, left border. I'm going to tell you the waters of the heart. This is the heart shadow in detail. It is just marked here: left subclavian artery, brachiocephalic artery, thoracic aorta. Okay. Next is these are the veins. So I'm not able to get it. I'm not able to take it. Okay. So I think everyone just look at this. I'm going to tell you the slides. Responding. Yeah. Next slide. Just 1 minute. Just so there is some stuck. It was stuck. I think it's stuck. Just stuck something. So just 1 minute. Hold on. Something is there. Just 1 minute, Laja. Just 1 minute. Hold on. Just
problem, sir.
Yeah.
You can see 4 X-rays.
Yeah. 4 X's. Yeah. Now it is there. Yeah. No. So after knowing this, marking other things, try to identify in the X-rays. This is the AP letter, AP view. Try to identify which are these locations. So this is the trachea. This is the trachea. Slowly you can able to visualize. This is the anterior ribs. It is not as conspicuous. This is the posterior ribs. It is conspicuous. This is the tracheal bifurcation. You can able to see the right, the right and left bronchus, left and left bronchus, slightly visible. This is the hilum. This is the descending aorta going down. Okay. This is the gastric bubble, which is there, we can able to identify. These are the diaphragm, the diaphragm. This right diaphragm little bit above the left diaphragm. Okay, and this is left hilum little bit above the left hilum little bit above the right hilum. Okay, left hilum is above the right hilum. So you just don't confuse it, because the diaphragm, the left diaphragm, because of the heart shadow, it will be lower because the heart is pushing the diaphragm to the lower side. So always right diaphragm will be higher, and the hilum is little bit higher than the right hilum. These things are there. Okay. Now I kept this. So try to identify. I have marked 1, 2, 3, 4, 5 things. So this thing will be given, and try to identify the structures as you go through this one. So this is the lateral chest X-ray. So you should have the AP and lateral view. After that, you will going to have a lateral chest X-ray. How to identify lateral chest X-ray? Don't bother about whether it right lateral or left lateral. So always make it a point to see that this your vertebral column will be the right side, and front of the chest X-ray will be in the left side. So we're going to identify it. So this one is nothing but 1 and 2 are the right. This is the right diaphragm and this is the left diaphragm. How can you identify that it is a right diaphragm and left diaphragm? First, you have to go back to the PA film and look at the heart bubble. Look at the gastric bubble. The distance from the gastric bubble and the left diaphragm, you have to measure the diaphragm and come back to the lateral film. Just look at the gastric bubble and then find out the distance. If the same distance, it will be the left diaphragm. Okay, so here it is 1 and 2. 1, this is the right and this is the left diaphragm. And this is the third one is the gastric bubble. So, okay, so this is the gastric bubble. And first and foremost things, if you want to know whether it is the right or left diaphragmatic, first measure the PU, measure the distance from the air bubble to the diaphragm. Then if the same diaphragm, same measurement will be there, then that will be the left diaphragm. Okay, if it is the diaphragm, somewhere around the same distance will be there in the PA view. This is the left diaphragm. If it is more, then it will be the left. Okay, like that only you have to identify. So this is nothing but 1 and 2 will be the gastric bubble. This is the retrosternal space, where this is very important. It is more darker than the other part of the film. And if there is any anterior mass, this retrosternal space will be obliterated. You should be very careful while doing this. Okay, and 6th will be the oblique fissure. 6th will be the oblique fissure, and 7th will be the hilum. The 7th will be the hilum. Look at the hilum. So you have to see the film regularly and identify, and then keep it in your mind. Then only you can able to assess the importance of this. Okay, this is the chest X-ray, and it is a 5 to 10 minutes. Videos will be there. So if you go on looking at this video, you're going to have an idea about this important structures in the chest X-rays. Now coming to the case scenarios. So this X-ray, yeah, this is the chest X-ray. A 22-year-old man admitted to the hospital, very short with breathlessness and requiring 35% of oxygen. This was X-ray taken. Describe what you see on the X-ray. So what is there it is? So I just told you earlier, this is the chest X-ray, nothing but a black and white film. So what are this one? 2 lungs should be there, and you have to look at the 2 lungs. So this is the right lung will not be, right lung is not appearing, it's a darker. And left lung is only small part of the left lung is appear, it is more darker. So the right lung, there is totally haziness will be there, and there is white. So one thing is there. So what are the other things we're going to have? And the cardia is very, very big. Cardiac shadow is very big in appearance. Okay. And third thing is, so we'll go into this trachea will be pushed. Trachea will be pushed to this side. This is the trachea. It is pushed to the right side, the left side. Okay. Trachea is put to the left side, and this whole thing is a haziness. And this cardiac border is also cardiac is bigger. So what do you think of this X-ray? This X-ray will going to have the pleural effusion. So I'm going to I got this one. In this X-ray, right lung is almost completely white, and the trachea and carina have been pushed to the left. There is no air bronchogram. That is very, very important. As I said, there is no air bronchogram, and there is obvious meniscus. There is no obvious meniscus in this. But there is no obvious meniscus. Meniscus is nothing but the fluid level and a concave part. The fluid level and the concave part will going to have a meniscus. There is no obvious meniscus even to say that it's a pleural effusion. But still, because of this air bronchogram and because of this pushing of this trachea to the left side along with the carina and the cardiomegaly appears, this is nothing but a pleural effusion. Okay. So the fluid, due to the fluid buildup of pleural fluid, so we're going to have this is a pleural effusion. So what is the next X-ray? This is a PA view of the chest showing a triangular homogeneous opacity on the right chest. So, okay, where exactly is there? So this triangular homogeneous opacity on the right chest with a curved upper border. Here, this is a curved upper border, which is concave medially and upwards and extends to the axilla. This is nothing but this right costophonic angle is obliterated, and this is haziness will be there. And lung margins also decrease. So you're going to have the pleural effusion. This is also a right-sided pleural effusion. So involving lower and middle lobes. What is the next X-ray? This X-ray, just coming to this X-ray. This X-ray is nothing but a 28-year-old man presented to emergency department with 1-day stay pleural chest pain. He was a smoker smoker for 15 cigarettes per day and had a strong family history of heart disease. What is the cause of his pre-operative type of chest pain? This patient present with a chest pain. Can anybody can look at this further? So just first and foremost thing is look at the both right lung as well as the left lung, heart border, hilum, and this any other bony part and soft tissues. Just look at these lungs. So because the patient is having a pleural chest pain and he is a smoker, so diagnosis should be lungs, inside the lungs. Just look at these lungs. You just hear some sort of darker apical region of the left lung compared to the right. I hope I'm clear. This is the darker and the edge of the edge is also visible. So what are the diagnosis? The lung field at the apex appears darker than the right. This could be due to increased shadowing on the right or lack of lung marking on the left. The lung edge is visible on the left side, as I said earlier. This confirms that the left apex is darker because of the lack of lung markings beyond the lung edge here and the presence of air in the pleural space. That means to say that it is pneumothorax, left-sided apical pneumothorax. Okay. Then this is a PA view of the chest, which reveals increased translucency on the right side of the chest with ICD in situ. So the ICD in situ itself will going to tell you the diagnosis. Okay. So with absence of bronchovascular markings, a sharply defined homogeneous opacity is seen lateral to the right cardiac border. So sharply defined homogeneous opacity. This is the right cardiac border. So right homogeneous opacity indicates a collapsed lung. Okay. So it indicates a collapsed lung. How will you say it's a collapsed lung? So the volume, loss of lung volume is still there compared to this lung. Okay, volume is also reduced. Okay, the right costophrenic angle is bit blunt, but left angle is clear. This is the left angle is clear, and this is blunt. Cardiac apex and tracheal shadow are shifted in the X-ray film, probably because of improper centering of the patient. How will you say centering of the patient? So centering of the patient is nothing but if you look how the patient is not rotated at the centering. So centering of the patient, I probably forgot to mention, the rotation should not be there. So when they rotate, how can you say this is the proper rotation is not there? Just look at the angle, the medial angles of each clavicle. Just look at the medial angle of each clavicle, and you have to take the vertebral column, spinous process of the vertebral column. The spinous process, the distance between the medial edges of each clavicle to the spinous process should be equidistant on both sides. If it's less or equal, the patient will be rotated. So you're going to have a problem. So that's the problem in this. Okay. Right dome of the diaphragm is bit flattened. Right dome of the diaphragm is bit flattened. The left lung field is appear clear and normal. So this is a case of what is collapse of the right lung because of this. Okay. This is a 45-year-old teacher present emergency following 4 episodes of hemoptysis. Are there any abnormalities on her chest X-ray? So definitely we're going to have a lot of abnormalities. Two things, as I said earlier, both the lungs, compare the both lungs. This lung is little bit looks bigger than they compare to the this one left lung. So that means to say that there is some sort of collapse of the lungs maybe there. Okay, some sort of collapse. So let us find out what is the findouts. This X-ray shows left lower lobe collapse. So this I pointed out here. Okay. The left lung field appears smaller than the normal, as I said earlier, and you cannot clearly see the diaphragm. So there is no diaphragm. Diaphragm cannot be seen. Behind the heart, you can see the line of the collapsed left lung. This is the line of the collapsed left lung behind the heart. This is called a sail sign. There is also a small left pleural effusion with a meniscus here. Because this is a small pleural effusion, it is also present because the left costophrenic angle is not clear. Is the left lower lobe collapse. A 30-year-old patient with a cough with greenish yellow sputum and a fever since 3 days. What is the diagnosis? So this is the X-ray given to you. So the Department of Emergency Medicine. So what is the diagnosis of this patient? This is a PA view. As I said earlier, it's a PA view because it is not written AP or anything. This is a PA view of the patient, probably PA of the patient, showing a big cavity occupying the right side head. Just like a cavity is there, big cavity in the right side head, mid or lower zones, thick, rough, and shaggy inner wall. This is the inner wall. This is a little bit thick and shaggy wall. The cavity is circular. The lower homogeneous opacity with an horizontal level indicates the fluid inside. This is the one. This is the fluid level, indicate the fluid level and a cavity and a hypertranslucency divide of lung markings. There is no lung markings above the fluid level. Just look at this. There is no there is no vascular markings are as such here. Okay, indicates air within the cavity. Air fluid level is a hallmark of lung abscess. This is the case of lung abscess. Okay. So we can able to make out it is a lung abscess with pneumothorax. Pneumothorax also can be here also is both are also there. So this is the X-ray. Can you make out diagnosis of this X-ray? Classical chest X-ray, and don't you should know the chest X-ray, darker films and a lighter and a haziness. Okay, darker films will be the pleural effusion, collapse, consolidation, pneumonia will be there in the the lighter lighter dark. It's not darker light, but when you go for a darker side of the you can make the diagnosis, able to make a diagnosis of COPD patients. Mostly the COPD patients, air within the lungs, it looks more darker. So this is a 70-year-old patient. So I'm not able to look at this. The thick green sputum will be produced, deterioration of the breathing. What is the diagnosis of this? Can you make a diagnosis? What is the diagnosis? This is nothing but COPD patient, exacerbation of COPD. So what are the classical findings in a COPD patient? The COPD patient is hyperlucency of the lungs because of arterial vascular deficiency. Arterial vascular deficiency because there will be hyperlucency in the lung in the periphery, and hyperinflation will be there. So a trapping of the air will be there inside the lung. So patient looks lungs looks hyperlucency. At the same time, look at the diaphragm. This is classically, look at the diaphragm. This is flattening of the diaphragm with the loss of normal domed appearance. So, and a vertically oriented cardiac chill out. This is called chill out, cardiac chill out. Cardiac chill out, nothing but a border and a contour of the heart. That is nothing but a cardiac chill out. If the cardiac border is not visible because of the lung, disease, the borders will be obscured. This is nothing but a chill out sign. Chill out sign means because of the disease of the lungs, the overlying cardiac shadow of a cardiac border will be disappeared. Okay, these are called the contours and chill outs. It's called chill out sign. So this is a cardiac chill out will be vertically placed. So this down of the diaphragm will not be there. It's a flattened diaphragm, and this is nothing but the emphysema or the COPD. So COPD patients. So chronic bronchitis is very difficult to make in a chest X-ray film. Please keep it in mind. Chronic bronchitis is clinical, and on the later stage of the disease, you will going to have the classic pictures of this chronic bronchitis. But this can make it out as a emphysema. How to confirm in a emphysema? If you have a bulla just like that, you will go into the confirmation of emphysema will be there. And clinically also you can able to always clinical correlation should be made with the findings in the chest X-ray, and always go for a radiologist opinion. So the radiologist, trained IFA radiologist is better than anybody else. You confirm with a trained radiologist whenever you find a lesion or whenever you are in trouble. Okay, this is, as I said earlier, lungs are whiter at the bases because apical hyperexcursion squashes the lower zones, pushing the blood vessels closer to the and overlying breast tissues. There is, however, no signs of consolidation because the hyperlucency of this lung. This is a 50-year-old male patient on ventilator. What does the chest X-ray shows? So this X-ray shows diffuse bilateral coalescent opacities not fully explained by effusions, lobar lung collapse or nodules. So we're going to tell you the findings of this later. So this is once again the chest X-ray showing the COPD findings. Increased bronchovascular markings, flattened diaphragm, a little bit flattened diaphragm, hyperinflated lung, okay, and a small heart. Okay, these three important things are confirmed the diagnosis of COPD. So this is also what are the chest X-ray shows. This bilateral diffuse spaces opacity sparing the apical and basal regions of the lungs. Sorry. Pleural spaces appear clear. Cardiomedicinal contours are unremarkable. Endotracheal tubes are also visible, and gastric tubes are in also good position. Okay, so what are the diagnoses? We'll go for this. So this is nothing but these are also nothing but the COPD features. Now coming into the what are the features we will going to have in pleural effusion, pulmonary edema. So pulmonary edema, so there are some initial stages. So initial stages is go on increasing. So when the pulmonary edema features, initial stages and the final stages. So initially there is a perivascular coupling. There's a pulmonary edema is evidence of initially when there is a pulmonary edema, there is evidence of pulmonary veins. That is at the upper lobes of the lung, the pulmonary distinction of the pulmonary veins will be there. The later part will going to have perivascular edema appears here, hilar region and perihilar edge. Perivascular edema Initially, the pulmonary veins will be distended. Later, you're going to have perivascular edema, and later part of the sign, you will going to have septal edema. So, the septal edema will be clearly seen in curly A, curly B, and curly C lines. So, and then subpleural edema. So, this interstitial edema, you're going to have subpleural edema later part of the sign, and finally, you're going to have alveolar flooding. These are the stages. So, of pulmonary edema. So, you have to be very careful. Identify what are meant by curly A lines and curly B and curly C lines. They will going to ask you, this is nothing but a septal edema. The curly A lines are nothing but septal edema, which reflects edematous interlobular septae in the upper part of the lung, upper lung fields. So curly B lines are the lower part of the lung fields, and curly relays edematous interlobular septae in the basal regions of the lungs, producing honeycomb pattern. So I'll go to depict this curly A lines. This is the curly A lines. These are the curly B lines, and these are the honeycomb appearance curly C lines. These are nothing but septate edema. So, okay, the edema will be increasing in the intensity. So, initial part, there will be only the distension of the pulmonary veins will be there in the upper part of the lungs. It will appear as a haziness. And later part, if the edema advances, it is increasing edema, there will be perivascular edema appears as hilar haziness or hilar or perihilar haziness. Later part, we are going to have septal edema, and then subpleural edema, and then alveolar flooding. Multiple opacities are produced in the whole part of the lung. Alveolar flooding will be there. That is the time where you have to diagnose going for ARDS. So you have to know what is the meant by ARDS, and they will going to ask you what are the definition of ARDS. How will you going to ventilate the ARDS patient? What are the recent treatment nowadays? They will this will going to have separate discussion. I don't want to go into the details of that. This just showed acute pulmonary edema. What are the features of acute pulmonary edema? Diffuse, as I said earlier already, the hilar haziness already appear. The haziness will be in the hilar region, both hilar. So there are no more conspicuous. Both the left and right hilar, both are not conspicuous. Okay, there will be diffuse perihilar space opacification. It's also called bad swing edema, and septal lines, curly A, curly B lines, and then honeycomb appearance also. There, all the regions are clearly visible in this X-ray. Next is, okay, this is also a case of pulmonary edema. So patient, as I said earlier, the question itself is self-explanatory. Patient will be having a cup of pink prodisputum. That itself is say that patient will be having pulmonary edema. What are the findings in this? This APV which just shows bad swing or maternal fluid appearance of confluent shadows which extend from the hilum to the lower zones. Just look at the hilum to the lower zones. Second thing is bilateral pulmonary clouding escapes peripheral and basal regions. So costophrenic angle is clear. Costophrenic, both the angles are clear here. Okay, both the angles are clear. That means to say that pleural effusion is ruled out. So I have given the diagnosis of Berlin definitions of acute respiratory syndrome, the staging of this one, and then the how to classification as far as the vaccination is concerned, mild, moderate, and severe. So PaO2 and FaO2 ratio has to be taken. Everything will be given here. Please go through this. They may ask you anything, especially the ARDS picture. They are going to put a ARDS picture, and they are going to ask you in detail about the ARDS. The student should prepare regarding the ARDS and the treatment aspect, the definition, the clinical features, a treatment aspect. What are the recent concept as far as the treatment of ARDS is concerned? The next, what this picture shows. So this is a 56-old man who has got underwent a laparotomy, lateral laparotomy, and is on ventilator. And what you see in the chest X-ray is clearly visible. This chest X-ray. So ET tube is inside. This is the ET tube. We can able to make out ET tube is inside. And next one is the central line. This is the central line is inside. What are these things? These are chest X-ray with the connections. This is the ECG chest leads with the ECG wire. These are the leads, ECG chest leads with the wires are connected here. And the right side, just look at the right side. So right side, the full haziness will be there, and you're going to have right fissural effusion. The fissure is there. Okay, this is the right fissural effusion will be there. Right mid and lower zone haziness. This is the upper zone. Upper zone is little normal. This is the right middle zone, and is the lower zone. Haziness will be there. So that means to say that some sort of, at the same time, right CP angle is blunted. So haziness will be there, and right CP angle is illuminated, some sort of fluid will be there. So that means to say that fluid is also present in these X-rays. Then mild innervation of the right hemidiaphragm also. Hemidiaphragm is not a little bit elevation of the right hemidiaphragm will be there. So the hemidiaphragm, both right side hemidiaphragm and left side hemidiaphragm, you have to compare always. The right hemidiaphragm will be the middle of the right lung, and the left hemidiaphragm will be a little bit lateral to the left left lung. So you should be keep it in mind. So always you should keep it in mind. So this may have some sort of atelectasis. This also have atelectasis. Fluid is also there. Some sort of atelectasis is also there. So edema, also features of edema is also there. At the same time, endotracheal tubis is there, and the central lines is also there, and ECG leads also there. Same to look at the cardia, the features of cardia. This is some sort of the maximum diameter of the heart. That's the maximum diameter of the heart is more than the 50% of the transverse diameter of the thorax. Okay, I will tell you how we're going to assess the cardiomegaly. Okay, later part of the one. So this is radiopaque line with the trachea, with the tip in the mid-tracheal, central line in situ, ECG chest leads, right facial effusion, mid. As I said, these are the findings which are kept in this X-ray. Now, next is what are this X-ray shows multiple opacities. This is self-explanatory, and this is most probably due to secondaries in the lungs. It's also called cannonball appearance, and maybe due to some sort of secondaries in the lung, which will going to appear like this. They will going to ask you what will going to do with this patient. So how will you going to assess this patient? Example, this patient may be having some breast cancer patient. I say the breast cancer patient with the multiple secondaries. How will you going to assess this patient pre-operatively? Whether you will going to accept this case for a surgery or not? How will you going to go ahead about the whether lungs is or not there? So first and foremost, you have to go for PFT, assess all the parameter of the PFT, and assess the patient is in a best possible condition to give anesthesia. They will going to tell you. They will going to ask you many things as far as this slide is concerned. Okay. Now we'll come to the kyphoscoliosis. So kyphoscoliosis X-rays will always maybe or may not be kept, but you should know this is the patient with the kyphoscoliosis. So they will going to ask you what is meant by a Kopp's angle. How will you going to assess the curvature, and whether how will you going to? There are some patients. So instead there are some patients who will solely come for kyphoscoliosis surgery. It may be incidental finding in a patient who was posted for non-scoliatic surgery. So you may have incidental finding. You have to take a fitness, and you have to assess the patient whether it is fit for surgery or not. For that, you have to assess the Kopp's angle. This is the curvature. So how to assess the Kopp's angle? What is meant by the Kopp's angle? In a scoliosis, if the patient is you take an X-ray, AP X-ray, and you find out what is the Kopp's angle. That if the 10 to 20 degree of the Kopp's angle is there, it is a mild. If it is 20 to 40, it is a moderate. And if it is more than 40 degree, it will be severe scoliosis. So you have to go for PFT, and if it is more severe, you assess clinically, and then talk with the surgeon, and then post-case surgery. So will you assess the Kopp's angle? So you have to take a chest X-ray, mark this. So the mark this where exactly the curvature is there. So curvature is there. Take the uppermost vertebra and the lowermost vertebra which is involved. The uppermost vertebra and the lowermost vertebra involved. So upper border, draw a line. This is nothing but an angle between the two lines, which is down. Commonly, Kopp's angle is nothing but an angle between the two lines, which is drawn in the upper part of the vertebra, which is involved, and the lower part of the which is involved. So you have to draw a line like this: upper part of the vertebra and the lower part of the vertebra. You have to draw a line like this, and after that, you have to draw a vertical line, vertically for this angle, for this line. When they meet, this is nothing but the Kopp's angle. Exactly, this is the Kopp's angle. I told you earlier, 10 to 20 degree, 20 to 40, and above 40. Above 40 is a severe Kopp's angle. You should be very careful as far as the patient is concerned. Now comes to what are this picture X-ray shows. This is an infant or a 7-day-old infant presented with emergency department with a breathlessness. So what is this X-ray? This is a multiple fluids are there, multiple fluid levels are there, and multiple tubes are also inserted here. So I think this is a gastric. I think this is a rice tube which is inserted here. So it is other, and most of the time this is the diaphragm, somewhere under the diaphragm. So you are going to have this what do you call this multiple fluid levels in the chest. You're going to have. That means that this patient is having congenital diaphragmatic hernia. So they will go into what are the diagnosis? We will make a diagnosis of congenital hernia. There are different types of congenital diaphragmatic hernia will be there. So patient will be presented with a breathlessness. Patient will be presented a severe breathlessness will be there. And this mortality is very high in these patients because of pulmonary hypertension. And this hypoplasia of the lungs will be there. And acidosis will be there. And you have to, there are different types of severity will be there. You have to assess. And what are the treatment options available for these patients? The treatment options will be, patient should be mechanically ventilated or ECMO should be given for these patients. So you should be very careful and you should know in detail about CDH. The next will be this is the coin. This is the coin which is present in the esophagus. So how will you make out that the patient is in esophagus? This coin is should be esophagus or it is in the trachea. If at all, if it is the trachea, patient will not be a very patient. Clinically, patient will be having stridor and difficulty in respiratory, and patient will be collapsed. So you should be very careful. They will going to ask you, how will you going to anesthetize this patient? What are the anesthetic implications of foreign body in the lungs or foreign body in the esophagus? So please go through in detail regarding this. Okay, this is the normal C-spine X-ray. So I'll go to depict what are the structure you will going to look at this. So vertebra and then pedicles and the articular facets, spinous process, all the three things, and hyoid bone, epiglottis, tracheal shadow. This is the tracheal shadow. Everything we're going to predict, and you should be aware of this normal C-spine X-rays. Now coming to so what is this X-ray shows? This is the 50-year-old female present with a history of dysphagia to solids, long-standing neck swelling. I think it is self-explanatory in this patient. The patient is having a huge goiter here, anterior mass, and the trachea is also this narrow trachea. This trachea is compressed, anteroposterior compressed. So they're going to ask you regarding this, the anesthetic management of a trachea on thyroid, and how will you going to intubate this trachea? Okay, that is also very, very important. This chest X-ray shows what are the chest X-rays. So what is the diagnosis? So this is a 25-year-old female present with the palpitations, okay, and breathlessness and exertion with history of fleeting type of joint pain and was on penicillin prophylaxis. What is the diagnosis? I think this is the chest X-ray. This this question itself is I think most of the lead to the diagnosis. So question is one is 25-year young patients with a fleeting type of joint pain with a penicillin prophylaxis. Most probably these patients will be having some sort of mitral stenosis or mitral valvular abnormalities. Okay, so what are the mitral valve? So they will going to keep this X-ray in AP erect. This is it is written AP erect. So these things should be written on the chest X-ray. So we be a bit careful while evaluating the borders of the heart. So what are the borders of the heart? So right border, right atrium will be there. Inferior border, left ventricle and right ventricle. Left border, left ventricle and some part of the left atrium will be there. And superior border, right and left atrium with great vessels. So you should keep it in mind. So now comes, how will you going to see this mitral stenosis? What are the stages of mitral stenosis? What are the X-ray? So X-ray appearance in the mitral stenosis. So how will you going to make a diagnosis of mitral stenosis? This is the POV of the chest, which shows mitralization of the heart. I will going to explain what is that mitralization of the heart. It's nothing but the straightening of the left border. You should know what are the constituents of the left border of the heart, from above downwards or below upwards, from diaphragm up to the hilum, or from above downwards, whichever way is. And the aortic knuckle, this is a small aortic knuckle is also there due to low cardiac output, and convexity due to dilated pulmonary artery. I will going to show it, pulmonary hypertension, and convexity produced by prominent left atrial appendages and a normal left border of the left ventricle. So we'll find out what is that. Okay. So this is, before that, I will going to go back to the same slide. Okay. This is the left border. Okay. This is the left border. From above downwards, this is the left ventricle. This is the border. And this is this is nothing but the pulmonary. This is the aortic knuckle. This is the aorta. From here also, aortic knuckle, pulmonary artery. Okay, and this is the left atrial appendage. So from above downwards is easy for you. This is the aortic knuckle. Okay, this is the pulmonary, the conus pulmonary artery. You will have to have a concave shape. Okay, this is the left atrial appendage. So this convexity will be lost whenever there is a left atrial enlargement. So and this is the left atrium. Okay, that is there. So we're going to tell you how it has to be done. Okay, this is the one. This is the mitral stenosis cause left atrial enlargement. One, this is written one. Elevation of the left main bronchus and splaying of the trachea. This is called left atrial enlargement. This they will going to ask you what are the pathophysiology And what are the X-ray findings in a mitral stenosis? The second is the left atrial appendage. This is the left atrial appendage, as I said earlier. So the convexity will be lost. The straight left heart border, left ventricle is smaller. Because left ventricle is smaller because there is a stenosis from the left atrium to left atrium. This is a hypoplastic left ventricle. So this is the left atrial, the straightening of the left border due to less blood flowing from left atrium to left ventricle. Right ventricle and secondary right atrial enlargement leads to opacity and double cardiac shadows on right. Okay. So you're going to have double cardiac shadow on the right side because there is a back pressure going on from the left atrium. It will leading on to the lungs. You'll go into a primary and secondary primary pulmonary hypertension. Later on, the secondary hypertension. Then later you're going to have the right ventricular hypertrophy will be there. So because of this right ventricular hypertrophy and the right atrial hypertrophy, you're going to have the double shadows will be there. Pulmonary vascular overload. That is called cephalization of the vessels. Pulmonary vascular shadows in upper lobes. Okay. So this is the pulmonary vascular will be there. These are the findings of mitral stenosis. That is X-ray findings of mitral stenosis. Should keep it in mind. So now comes to the cardiomegaly. How to find out how to measure the cardiomegaly. This whenever there is a cardiomegaly is given, your maximum cardiac length has to be measured. Okay, from here to here, and then measure the transthoracic diameter. Okay, this length should be less than half of this one, this total length. Okay, so I have depicted here also. Sorry, I depicted here also. So A plus B, this is the one. A and B, they have down a midline. This is the A, this is the B. They have taken this the reading. These have taken this, both the reading they have taken this, and this is the taken. This is the C. Okay, A plus B DCY is more than 0.5%, then cardiomegaly will be there. So if it is more than that, more than the 0.5%, it is cardiomegaly. And I think I am more clear. It should be very soon. This is very easily you can able to make out. Okay. So look at this figure. So what is this? We're going to have lungs, the heart shadow, some sort of abnormal things are here, and here also abnormal things are here. Okay. So these abnormal shadows are here. So this is nothing but valve. This is the pulmonary. This is nothing but a mitral valve. Is exactly here. Mitral valve will be there, and this sternotomy sutures are also visible. So patient will be having mitral valve. Okay, they're going to ask you what are the types of valves. Prosthetic valves. What are the types of valves? That is prosthetic valves, mechanical valve, or bioprosthetic valve. And what are the mechanical valve? Which is very important. And when do you advocate mechanical valves or a bioprosthetic valves? They will going to ask you in detail regarding the valves. Next, this is the picture showing the boot-shaped heart. This is nothing but appears in tetralogy of Fallot. So what is this tetralogy of Fallot? The tetralogy of Fallot has the components of pulmonary stenosis, overriding of aorta, ventricular septal defect, and right ventricular hypertrophy. All these will going to produce a classical picture called boot-shaped aorta, boot-shaped heart. The boot-shaped heart, because of this, also called Courant-Chabot in French. This is also called Courant-Chabot in French. What is the first abnormality? One thing is upturned cardiac apex. Because of the right ventricular hypertrophy, this cardiac apex will be upturned. This is the cardiac apex, which will upturned cardiac apex. What is the second? Pulmonary artery segment concavity. This is the pulmonary artery concavity will be there. This is the pulmonary artery concavity because of the pulmonary arteries, because of the pulmonary stenosis. The pressures are very high because the pulmonary stenosis is going to have the pulmonary artery concavity. And then the enlarged aorta, aortic shadow will be enlarged here. And the second is lungs are translucency. The hypertranslucency of the lungs will be there. It is called oligemia. Okay, lens of translucency. So these things are nothing but a boat-shaped heart, and you should keep it in mind how to diagnose a boat-shaped heart. The next is the egg-on string appearance. Okay, this is the classical example. You cannot forget these things. So transposition of the great vessels, cardiomediastinal chill out. It's called cardiomediastinal chill out. As I said earlier, chill out is nothing but obscuring the cardiac heart border. Okay, abnormal convexity of the right border. It's very abnormal. Right border is not at all visible, and left atrial enlargement. Both are there. So you're going to have this egg-on string appearance in a transposition of great vessels. Then is outposition ventricular aneurysms. These are the classical example, and this is nothing but pericardial effusion. Because of the pericardial effusions, this just like a water bottle which is kept on the table, and it's also called money bag appearance. Okay, these walls are where the cardiac waters will be stretched, and this is going to give a classical appearance of a water bottle or a money bag which is kept on the table. Now come to the, because of COVID, we should know what are the X-ray findings in COVID allergy. I don't want to go into the details of this. So most probably first and second wave, we have got this lot of lung involvement in this COVID, but you should know what is meant by this because this involvement is very varied in this COVID, but there are some classical features which are present in the first and second wave of COVID. The most frequent findings are airspace opacities. The distribution is most often bilateral, peripheral, and lower zone predominantly involved. Findings are most extensive at about 10 to 12 days after the symptoms onset. Daily chest X-ray has to be taken for COVID-19 patients, and they have to be evaluated repeatedly. Every day you have to evaluate. It is not definitely I also undergone this, and it is really so annoying to some patients, and you have to treatment should be aggressive. Otherwise, very difficult in these patients. So this is all the typical. Sorry. Yeah. So chest X-ray grading, I think everybody knows whether there are 8 lobes, there are lobes are involved. Depending on the lobes involved, we will going to have whether the percentage of lungs involvement or the lobes are involved. We're going to have a scoring. They're going to have severity scoring. But nowadays there is a lot of confusion regarding the severity scoring, and the people will going to give you the scoring in these patients. So if there is a mild, moderate, and severe as far as the 10th day of the involvement, and as far as the oxygen requirement is concerned, you will going to going to have that. Thank you very much for a patient hearing. Any questions? I'm going to take it. Rajesh?
Yeah, we'll go to the chat box. I don't think any questions or comments in the chat box.
Okay.
And it's open for discussion. So any comments or questions from the postgraduates or senior faculties?
No, I have shown you only the classical X-rays which has put it, which has for the emergency, which are the classical X-rays which are going to put it in the examinations. So only thing is repeated looking at the X-rays can able to answer this. Rajesh?
Yeah, there is Anil Parekh, good Anil Parekh, sir, you can unmute and give your comments, please. Dr. Anil Parekh.
Shamshad madam is also there. Paul sir.
Yeah.
Yes, sir.
Sir.
Sir. No, I have put some classical on X-rays which we kept in our examinations. The same examination, the chest X-ray I kept it, and we have just finding that one animation X-rays are there. I think it is a 5 to 10 minutes. So you can put it in the YouTube. They'll pay that it is self-explanatory. I think 10 minutes. I did not put it here in this one lecture. I think it is in the slides, PPT slides. Rajesh.
Yeah. Okay.
It was really a good revision of the X-rays. It was very good.
Thank you, madam. Thank you, madam. Thank you.
Okay.
Yeah, hello.
Hello.
Yeah, Dr. Rajesh.
Yes.
Yeah, I'm Dr. Anil Parekh. Thank you.
Sorry. Good evening.
Yeah. Good evening. So thank you for sending me the link, and Dr. Manjunath was really very nice presentation, and totally agree with you. Your collection is totally good, and it is very helpful for the DNB students for the exam. And not only the X-rays, but you have how the examiners goes for the X-ray to the case discussion, that you very nicely presented. So the people will be quite benefited with this. So thank you very much, and very nice X-rays collection, Dr. Manjunath. Thank you.
Thank you, sir. Dr. Anil Parekh is senior faculty of IS Mumbai. He's HOD of Global Hospital Mumbai.
Yeah. Thank you, Rajesh. Thank you.
Thanks.
Thank you.
Dr. Sripada, you put some comments.
Good evening, everybody. Thank you for sending me the link, and I'm attending the events most of the time. I don't like to miss your programs. They're very nice. Dr. Manjunath has given very good X-rays and their explanations, and approach is very systematic. That is very important. When PG reads X-ray in the exam, they should go very systematically, and then they arrive at a conclusion. Then examiner has got a clear-cut duty to ask that particular question, so they can actually lead them where they want. Excellent presentation.
Thank you, sir. So postgraduates, any queries or any questions? So many of the postgraduates are appearing for exam on 24th. Hope it will benefit them also. And postgraduates can still post their questions, but if there are no more questions, we'll go to next session. That is Professor Mallikarjuna. He'll be presenting on hypertension. So this is a topic which is very relevant or important for both for the theory as well as for the practical sessions for hypertension, because you know it's one of the most commonest comorbidities any patient can have, and you'll be asked questions like how do you prepare the patient with hypertension, to what level of cutoff value you will take up for patient, or in an emergency scenario how will you control the blood pressure. And to know about all these things, we have Professor Mallikarjuna, who is a professor at Sullia Medical College, Bangalore. Actually, he's a native of Bangalore, and he did his DA and MD from KMC Bangalore, and he worked there for some time, and in Anapaya Medical College, and presently he's attached to KVG Medical College, Sullia. And his passion
sir,
is
can you stop
1 minute,
sharing?
Sir, 1 minute. Yes, Paul sir. Rajesh, can you
Yeah,
hear me?
yeah,
Rajesh,
please. Yeah.
I think in the audience poll, Dr. Nagalakshmi madam is there. She is my professor and head of the department. She is my teacher. She is also there. And I said this, I saw her. If you can ask for her opinion regarding that, she is also there.
Please. Yeah, please.
Madam is also there. Dr. Nagalakshmi, NV Nagalakshmi is there. She is a senior most professor. She is a teacher to me and as well as Shripad also.
Okay.
She was there. I think she was there.
Madam can unmute and put their comments.
Dr. Nagalakshmi madam. Good evening, madam. I think she is not there. I think
She
Rajesh
has left. She is not
okay.
there.
Okay. Okay. Thank you, sir. Paul sir.
No, thank you, sir. Thank you so
Okay,
much.
sir.
Thank you.
Sir.
Shamshad madam, any comments? Or otherwise we'll go to hypertension and anesthesia.
So we can go to the next session, hypertension and anesthesia. It was a really useful Manjunath sir talk on X-rays.
Thank you, sir. Thank you, madam.
Thank you, Dr. Manjunath.
Thank you.
It was a good session.
So, Dr. Rajesh, I just want to make a comment for the PGs, because many times when the X-rays are given to them, we must see the central line position. That is very important for the anesthesiologist. So when you're analyzing these patients, particularly in ICU X-rays, as Dr. Manjunath had already told in one of the 2 lectures, but many times in pediatric patients, the central line goes from right jugular vein to left jugular vein, or it will make level in the subclavian vein and all. So when the PGs are seeing the X-rays, they must confirm the position of the catheter, central line venous catheter, and that is the reason we mandatory do the center X-rays after all the central line catheters. That's the only comments I want to make. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Mallikarjuna, sir.
Yeah, we go to next session.
I'm here.
Yes, over to Dr. Mallikarjuna.
So I should start sharing.
Yeah,
Sir, please.
It is already shared.
Shared, eh?
Yeah, we can see.
Okay. Yeah, is it on slideshow?
Yeah, it's on.
Yeah.
1 second. Yeah. Okay. Good evening to ISA Kerala, all my seniors, my friends,
Dr. Venkatagiri, Paul, Shamshad, can you hear me?
Yes.
Okay.
Yes, sir.
To all the webinar coordinators and to all my dear postgraduates, it's a big pleasure for me to be a part of ISA Kerala today and talk to you on hypertension and anesthesia. As everybody know that in our day-to-day practice, I think every fourth patient is an hypertensive. So it is always better to know that hypertension is one of the most important diseases we come across. I would like to discuss this topic with the following headings. I want to give an introduction to hypertension and anesthesia, tell how you can define hypertension, classification to know how we can go about managing hypertension and anesthesia, what are the types of hypertension, a brief mention I'll be doing about the maintenance of blood pressure in a normal individual. And the most important part of this discussion will be all the hypertensive drugs which are in use and their anesthetic implications, the perioperative management of a patient posted for surgery. The most common, as Rajesh was telling, Professor, that what are the anesthesiologist's dilemma when you come across a patient with hypertension? Many a times you have an hypertensive patient who's diagnosed first in your preoperative visit or when the patient is posted. I'll be restricting myself to elective procedures. So I'm telling this, that when you get a patient with hypertension in your preoperative visit, it is important to know that whether to treat and operate. I want to discuss whether you want to postpone. If you take up the procedure for surgery, what are the risks involved? What could be the cardiovascular responses in treated and untreated patients? A few recommendations and conclusions. I would also like to answer, especially for the budding anesthesiologists, that when you should take up a patient for surgery, that is, what should be your cutoff blood pressures. And if you postpone the surgery when posted for elective, I would also like to tell you what should be your target for taking up these patients. Suppose you get the patients with 160, 170 by 100 blood pressures, how you want to treat them and what should be your cutoff targets for the blood pressure and how much time you want to take them to treat them before you take up, and what should be your intraoperative target blood pressures. As I said, nearly, I have mentioned 40, but some literature says more than 50% of our adult patients are hypertensive 1, and more than 50% of these hypertensive patients are not treated properly. They are inadequately treated, irregularly treated, and when they come in, especially for an emergency surgery, it makes management of anesthesia a big problem in the problem of having complications. And to note down that 15 to 20% of our adult surgical patients are hypertensive, which makes every third, fourth case to be an hypertensive. Postgraduates, remember that one of the reasons why in our elective list, a case gets cancelled or postponed, other than upper respiratory tract, hypertension comes on the top. Though there are many other conditions where we would postpone a surgery, especially when posted for elective surgery. There are other reasons which I want to tell the postgraduates which can get cancelled, maybe because of patient-related. He's not maintained his IPO status, he's not brought his relative, or some reasons why we cancel. And the hospital may be responsible because they would have put up a huge list and the list cannot be finished and you have to postpone the surgery, or the beds are not available, or some technical problems arise. But remember that hypertension for an anesthesiologist is second most common reason why a case gets cancelled. Why hypertension is a worrying problem for postgraduates and for anesthesiologists. Whenever a patient is having hypertension, it forms a major cardiovascular risk factor where the patients can have ischemia. Not only ischemia, can have hypertension, can develop myocardial infarction, can have a pulmonary edema, so many events. Along with cardiovascular, we are also worried about the vascular complications, increased amount of bleeding, central nervous system problems that patient can develop, cerebral edema, which can lead to delayed recovery. Patients can have a hemorrhage. So the other reason is, if you go look at some of the risk stratifications in our preoperative assessment of patients, hypertension is never there in most of these. So it makes us more responsible when we are managing a hypertension patient, because we can develop CNS, CVS, and renal complications when we take up these patients. Coming to the definition of hypertension, whenever the latest recommendations are whenever the blood pressure is more than 130/85, we consider them as hypertension. Don't consider hypertension as just a value, but it is a disease which in early part of its progression may not have end organ, but subsequently will have end organ damages in spite of being well controlled. All those patients with normal tension, but they say that they have been on antihypertensive drugs, are also hypertensive patients. For the benefit of postgraduates, and I found this classification, though today it has been classified into normal and just stage 1 and stage 2. For the anesthetic management, I always prefer to put them in this classification as optimal being when the blood pressure is below systolic of 120 and diastolic of less than 80, which is what everybody prefers. A patient with normal is considered normal when his systolic pressure is 130 and diastolic 85. High normal is what most of them say when the blood pressure is between 130 and 140 and diastolic pressure of 90. Stage 1, 140 to 160. Stage 2, 160 to 180. Stage 3 is more than 180 to 210, and severe is 210. And diastolic pressures accordingly, what I have put up on the slide. Everybody know that what are the types of hypertension we come across in our practice. 95% of our hypertensive patients are having essential hypertension. Though essential hypertension is one where the cause is not known, but there are so many factors which have been implicated in this development of essential hypertension. The most common among them are obesity, which is supposed to help the patient if they reduce the BP, high sodium intake, sedentary lifestyle, smoking, alcohol intake, to name a few. There are many causes of the remaining 5% where we know the cause of hypertension, which is called a secondary hypertension, thyrotoxicosis, renal parenchymal disease, pheochromocytoma, renal artery stenosis, Cushing syndrome, hyperaldosteronism, to name a few. What are the complications of hypertension? Why I put this slide is, many a times we as anesthesiologists may encounter a patient who has not been diagnosed hypertension and comes to us with one of these complications of hypertension. Because hypertension in many people, many patients, as they go on having their blood pressure on the higher side, they get adjusted. There is whatever called a shift of the blood flow and this one to the right, and they may present to you with the complication. Most common complications we come across are congestive cardiac failure. Patients, when on preoperative findings, we find that left ventricular hypertrophy with diastolic dysfunction is one of the commonest. They have never give history of any hypertension, but this is a dreadful condition when we get left ventricular hypertrophy, which is diagnosed on your investigations with ECG and echocardiogram with the diastolic dysfunction, may have a lot more complications. And
Madam.
Yeah.
Madam, Vijesh take over. Okay. Last session. ഓക്കെ ഓക്കെ മാഡം, പ്രോബ്ലം ഒന്നും ഉണ്ടാവില്ല മാഡം.
Rajesh,
പിന്നെ അടുത്ത 5-ാം തീയതിയാണ് അടുത്ത മീറ്റിംഗ്.
Can I continue?
നമ്മള്
yes.
ഞാൻ മുബാറക്
Yeah.
സാർ
There was somebody talking. Okay. Other complications include myocardial ischemia and infarction. Patient may come with aortic aneurysm. Of course, coronary artery disease can develop because of continuous damage of the high blood pressures on the vascular system, which results in aneurysm, atherosclerosis and dislodgement of the plaques. For the first time, many a times we have come across patients who are hypertensive, not diagnosed, not knowing about it, coming with high blood pressures and developing cerebral edema and encephalopathy. Stroke is one of the common causes of presentation of hypertension with cerebral hemorrhage. Patients can come with chronic renal failure. We realize that the reason for this chronic renal failure has been hypertension. Patients may have retinal detachments and blindness. So why should, as an anesthesiologist, know the therapy what you use for hypertension? Because it is vital to an anesthesiologist to tell our patients in the pre-operative period how you can keep their blood pressures under control. Number one is by using non-pharmacological therapy, and among them, the most important is reducing weight. Patients who are on medications but still not under good control are advised to reduce their weight, change their lifestyle, become active, do some physical activity, reduce their sodium intake. If they are alcoholics, to stop alcohol and stop smoking. But more important for the anesthesiologist is what drug the patients are on. And probably sometimes we may have to use these medications in our intraoperative or perioperative period, even without the consultation of a physician or a cardiologist. These are classified into a group of 5 drugs which the patient is on. The order is not in the right order, but the most common drugs which are used are diuretics. I would put AC inhibitors next, calcium channel blockers, alpha blockers, and beta blockers. In that order, what the patients can be on. The patients can be on monotherapy. Usually everybody knows that once the patient is detected hypertensive very recently, maybe just on diuretics, and if it is not controlled, he goes into polytherapy or a dual antihypertensive. With diuretics, you add on AC inhibitors or ARBs, then you may have to add on calcium channel block. The combination of the drug depends on the patient's condition, his end organ involvement, and how better he is controlled. Vasodilators are usually, other than calcium channel blockers like sodium nitroprusside, nitroglycerin, hydralazine, are used in the management of hypertensive crisis more often in the intra-op or the post-op or the intensive care units. Once you know what are the drugs which the patient is on, it is also important that we should know the mechanism of action of these drugs, because by knowing the mechanism, we can use the right anesthetic drug when we are managing them for general anesthesia, the right techniques to be used, and the right vasopressors or inotropes to be used in case of hypertension and hypotension which develops intraoperatively. I just want to briefly tell about the mechanism of action, how beta blockers and peripherally acting sympatholytics act. They usually decrease the cardiac contractility and the heart rate, which helps in reduction of the cardiac output, hence reduction in the blood pressures. Beta blockers, along with AC inhibitors and diuretics, also act on the renal system by reducing the sodium uptake and excreting the sodium. We all know that water follows the sodium. This helps in reducing the blood volume and hence reducing the cardiac output, and hence will help in reducing the blood pressure. As already mentioned, calcium channel blockers, vasodilators, AC inhibitors, and ARB also have an additional action other than the renal. AC inhibitors and ARBs, they dilate the peripheral vascular system, especially the arteries, which helps in reduction of peripheral vascular resistance or systemic vascular resistance. And this helps in the reduction of the afterload and reduction of the blood pressure. One should also remember that the vasomotor center, which are located in the pons and the medulla, mainly in the medulla and partly in the pons, and these are responsible for the sympathetic outflow, which help in increasing the sympathetic outflow when the blood pressure falls, and reducing the parasympathetic outflow will reduce the blood pressure, or help in increasing or decreasing the blood pressure. They decrease the sympathetic outflow and hence decrease the cardiac output and decrease the peripheral vascular resistance and help in reduction of the blood pressure. Why, as an anesthesiologist, you want to know about these antihypertensive and their anesthetic implications? It is mainly because of the drug interactions, and because there are wide variety of drugs being used in the management of hypertension with wide trade names. It is always important for an anesthesiologist to recognize the drug, what the patient is on. Just don't depend. Earlier, when we used to ask the size of the tablet, how many times he used to take, many a times he would be able to recognize what the drug the patient is on. But today it is not the thing. The postgraduate should always ask the patient to get the prescription, get the tablets, read the drug, because there are wide variety and they can be very potent drugs. And without the knowledge of these drugs, if you go and anesthetize the patient, you may end up with more problems. And another reason why you have to know about this antihypertensive, the dictum in managing a hypertensive patient who's on antihypertensive drugs is that the patients are asked to continue, are recommended to continue the antihypertensive drugs till the morning of surgery and restart as early as possible in the post-operative period to prevent the complications of stopping these antihypertensive drugs. Briefly, to tell you about some of these drugs and their interactions, diuretics are the first line in the management of, after you have told the psychological, non-pharmacological methods of reducing, diuretics fall in the first line of treatment in most of the patients who are diagnosed hypertensive. How do they act? How do they produce? And what are their problems when you come across? You remember that when the patient is on acute therapy, probably he says that I was diagnosed hypertensive about a week or 10 days or 15 days back, and I was put on diuretics. Remember that the fall in the blood pressure in these patients is because of reduction in the blood volume, because they act on the renal tubules to either excrete the sodium, and along with that the water goes and cardiac output reduces, extracellular fluid volume reduces, which is more important for us, that when the patient is on acute therapy, induction of anesthesia as well as your regional techniques can result in severe hypotension. Initially, there is an increase in systemic vascular resistance when you put them on diuretics. Once the patient is on chronic therapy for the management, once it is for more than 4 to 6 weeks, the blood volume normalizes, and the fall in the control of blood pressure is because of the reduction in the systemic vascular resistance. Also remember that thiazide drugs are less potent, and loop diuretics are more potent when you put them on treatment. Hypokalemia and metabolic acidosis are the prime worry for an anesthesiologist when they are on chronic therapy with diuretics. When you are initiating these drugs in a patient, be sure that they are not on digitalis and try to avoid them when already they are having an irritable myocardium with ectopics. When you put the patient on diuretics, it may precipitate a gout. The lipid profile may change because of increase in the concentration of serum lipids. Don't forget about the potassium sparing diuretics like spironolactone and triamtrene, which to prevent hypokalemia in some of the patients. These were some of the drugs which were used very often in management of hypertension. That is the centrally acting drugs like, of course, clonidine is today used for other reasons in our pain management, in our sympathetic stimulation, as an adjective to spinal and epidurals. Methyl dopa is still used in gynecological practice, obstetric practice to reduce the blood pressure. But when these patients are on this, sudden stoppage of these drugs can cause withdrawal hypertension, which can be very high. Since they act centrally, make sure that patients with psychiatric disorders are not put on these drugs. And when the patient is on tricyclic antidepressants, it indicates that these drugs should not be used. You should remember when you give anesthesia to these patients that these cause some amount of central sedation. Try to reduce your sedative drugs in your pre-medication. The MAC value is reduced and the doses of induction agent is also reduced. If you use the regular dosages, you may end up with delayed recovery because the patient is on chronic therapy with these drugs. Beta blockers, which are commonly used in most of the patients, especially hypertensive with IHD, are the ones who are on these drugs. I'm not going into the classification. You come across lot number of beta blockers. They can be cardioselective, non-cardioselective, which are selected by the physicians according to the disease what they are suffering and hypertension with IHD. But what we have to know is the patient severely or beta blocked patient, when the heart rate is around 30, 35, 40, it may be dangerous to give spinal, epidural or general anesthesia to these patients if they are not responding pre-operatively to either when you stimulate them with dopamine or with atropine or glycopyrrolate. And patients who have an adequately controlled heart rate 45 to 50, 55 on this one, we should make sure that they will respond to severe bradycardia, especially when the interactions, what we come across is if you add halothane to patients who are, of course, halothane is in many of our, this one is not used, but for the postgraduate students, they should remember that beta blockers and halothane can cause severe bradycardia. And when you give suxamethonium to patients who are on beta blocker, can have severe bradycardia. Of course, neostigmine and vecuronium can also cause bradycardia. When the patient is on beta blockers, remember that your hypovolemia will not respond by causing tachycardia because of the beta, your hypovolemia being masked. So monitor the volume losses in a better way. Also, in a diabetic patient on beta blockers, hypoglycemia may be not recognized with tachycardia and sweating. Alpha blockers can be used in some of the patients, especially with who are on prostate enlargement. Remember that when you give anesthesia to these patients, you may have severe hypertension. Calcium channel blockers are known to produce hypotension, tachycardia, and palpitation with your intravenous agents. Can interfere with your non-depolarizing muscle relaxant. Coming to AC inhibitors and anesthesia, this is one of the most controversial subjects for most of the postgraduates, because you are asked in the exam, you want to continue, you want to discontinue. Why you want to continue, why you want to discontinue? I would say you want to continue because the recommendations are continue all antihypertensive till the morning of surgery. Why you want to discontinue? Because these can cause severe hypotension following induction of anesthesia. And why do these cause? These usually act on the renal system and can cause severe hypertension with your induction of anesthesia as well as with your GA. So you may have refractory hypotension, how to treat it, but there are people who say that if you are continuing these drugs, you can always preload the patient before your induction, use titrating doses of the drugs before you stop these drugs. Do not use these in pregnant patients because are known to cause petotoxicity. One of the common antihypertensive drug which was used in those days was reserpine because of the cost. These depleted the catecholamine stores in the body, and with induction of anesthesia will cause refractory hypotension. And remember that if you have to treat this hypotension, you may have to use direct acting vasopressors. Indirect acting vasopressors, as postgraduates should know, that act by releasing catecholamines in the body to increase the blood pressure. So what you want to look for a patient who comes as an untreated patient, the patient says, I have never been an hypertensive, but on your evaluation, on your repeated checking of the blood pressure, he is found to be having blood pressure. As already I have said that patients can have left ventricular hypertrophy with diastolic dysfunction. There can be, these patients can have damage of the vascular epithelium, which can result in atherosclerosis and ischemic heart disease and cerebrovascular accident. Look for nephropathy in these patients. Look for congestive cardiac failure. And if you go ahead giving anesthesia to these patients can have very labile fluctuations in blood pressure, both on the hypotension and hypertension, which are not good for a patient who has been hypertensive for a long duration of time and can result in almost all end organ damage if you go ahead do these cases. Of course, in case of emergency, you have to do, and a well-managed patient can still go well. Coming to a little bit of management of anesthesia in hypertensive patient. This is always individualized. The surgeon who can, the anesthesiologist who can manage general anesthesia, regional anesthesia, there is no contraindication. It all depends on how the patient is assessed, what pre-medication you are giving, what anesthetic technique you are using. Both can be managed well. But everybody, when you come across an hypertensive patient, we are always want to give regional technique like brachial blocks, nerve blocks, spinal, epidural. The reason being we are avoiding interfering with the hyperreactive airway, which is one of the most reason for hypertension giving during anesthesia. A bad laryngoscopy and bad induction can result in a lot of blood pressure shooting up. But even when you are giving regional techniques, there are problems in hypertensive patients. First of all, try to see whether you have assessed the patient well. Is the patient having any associated coronary artery disease? Look for the ejection fraction, look for the cardiac function. If the patient's cardiac functions are not adequate, if the ejection fraction is low, since I've been practicing a lot of uro, I come across patients with hypertension, IHD, with ejection fractions of 25. Is it safe enough to give spinal epidural? If you well manage, if you know how to do it, yes. But for postgraduates, I would always advise to answer in the exam saying that I would be more comfortable giving general anesthesia for a patient with very low ejection fractions. Again, without all these problems, when you give a spinal epidural, you may be asked in the exam, what do you prefer in a hypertensive patient? Okay, you decide regional techniques are good enough for these patients. Should I give spinal or should I give epidural? I would give spinal because the end result is fine and the block is definitely going to act. But the reasons why I'm worried is that there can be sudden fall in blood pressure. You may have to push in vasopressors. and all those things. Epidural can always be graded, and so that the fall in the blood pressures can always be much lesser, much better, well controlled. So both can be managed. In the advantage of epidural will be you can prolong the duration. You avoided giving general anesthesia because you did not want to interfere with the airway, and you can give post-op analgesia in these patients. So with this introduction to the perioperative management, what are your goals of anesthesia? A good pre-operative evaluation. Try to reduce the risk in your perioperative period. Go for very good pre-medication with sedatives and narcotics. Plan whether when you are giving general anesthesia for a balanced anesthesia, spinal and epidural. Already I have spoken about use monitors what are required. Don't go for unnecessary monitors. Monitoring depends on the patient's condition, the extensive nature of the surgery. Keep your parenteral antihypertensive ready to manage any hypertensive crisis intraoperatively. When you assess your patient in the preoperative period, you try to know the duration. Longer the duration of hypertension, more the end organ damage and more complications available and in your management. Again, when you ask the treatment, ask whether the patient is on regularity or he has just taken it for many a times. We come across patients who take it for some time. Then when they go check up, the blood pressure is normal. They say that it was normal, so I stopped it. And some of them stop it and will not go check their blood pressure. See whether they are taking regularly or irregularly. A patient who's on irregular treatment is always going to give you headaches during your management. So it is important to know whether they are controlled or uncontrolled. If they are uncontrolled hypertensives, again, the fluctuations will be more. A controlled hypertensive patient will behave almost like a normotensive patient. Look for end organ damage, especially the cardiac, renal system. So you can avoid some of your techniques, make use of good techniques, the good drugs, which can prevent further damage to these organs. Find out whether the patient was admitted earlier for any complications for hypertension or its end organs. Any previous anesthesia in these patients will give you confidence of not having or how it was managed earlier. On your general physical examination, most of the hypertensive patients will not have any findings other than the raised pressures. Coming to the systemic examination, you have to look for right heart failure and left heart failure. If any, for example, a raised JVP, tender hepatomegaly, pedal edema will indicate right heart failure, and an S3 gallop, cyanosis, crepitation and breathlessness, plus if an S4 is per left ventricular hypertrophy, will all help you towards the diagnosis of left ventricular failure. What's your pre-medication in this hypertensive? Put continuation of antihypertensive on the top of this, because before even telling about the sedatives, I will say that continue antihypertensives till the morning of surgery, which will include the dose on the previous night. Use judiciously sedatives, because you don't reduce the amount of sedatives and increase the anxiety in these patients. In this aspect, I would say psychological pre-medication is important. Go spend some time with your patients. Don't straight away start taking a history. Don't straight away start examining the patient. Ask about him. How are you? How are you feeling? What are your this one? Develop a rapport. Where do you come from? That will all reduce when you ask about the patient. Tell him that nothing is going to happen. Everything will be fine. You are in the best hands. You are in the best hands of the surgeon. Such giving is important, that itself will reduce the blood pressure of these patients and will behave very normal. Narcotic pre-medication is important on the morning of surgery, because especially morphine in an hypertensive patient with IHD has advantages, which I'll tell you in the subsequent. Assess the blood pressure, review the records, because day on which you go and examine, the blood pressures may be normal, but when you check the blood pressures for over a week or 3 or 4 days, you may find it to be very fluctuating. I don't want to talk much about white coat hypertension, which has to be ruled out before putting the patient as hypertensive. So what are the intraoperative situations are the time when you can have hypertension in these patients? First and the foremost is laryngoscopy and intubation, because this, if it is managed well by any postgraduates or any hypertensive, any postgraduate or an anesthesiologist, remember that do a quick laryngoscopy and a smooth laryngoscopy within 15 seconds will give you the best results. And if you do a smooth intubation, don't, as postgraduates, I always advise, when you have a patient like this, don't give it to your junior most postgraduate to intubate this patient. He may take a longer duration. So see that it should be an easy intubation. The laryngoscopy should be short, and see that you have induced the patient well. There are, of course, drugs like beta blockers, your Xylocard, and many other drugs, narcotics, which can be used before laryngoscopy about 45 seconds to prevent this sympathetic response. Avoid hypercapnia when you are given general anesthesia. Nobody is giving you hypercapnia, but keep a watch on your circle absorber, which can get exhausted without your knowledge and cause hypercapnia. If you have a capnograph, that will always indicate you about the carbon dioxide levels. Of course, hypoxia is also indicated in hypertension. When the patient is ready for the surgical incision, see that the depth of anesthesia is adequate. Postoperatively, bladder distension should be avoided, which can cause hypertension. But one thing I would always suggest is, we come across hypertension suddenly intraoperatively, who was normal, could be because of an undiagnosed medical condition, could be a thyrotoxic patient, could be a pheochromocytoma. And whenever you have induced a patient, whenever you're given a spinal or epidural, there may be hypotension. Don't use the inotropes and vasopressors like in a normotensive patient. Try to titrate these drugs, otherwise the blood pressures can go up so high. Or sometimes inadvertently you have pushed in some of these inotropes or vasopressors, which can result in hypertension. You have to take the same precautions during extubation to prevent hypertension at the time of extubation. Some of the surgical conditions which could result in hypertension intraoperatively, where you may have to give vasodilators before they do these procedures, or be ready. One is aortic cross clamping, AV replacements, carotid endarterectomy, and PDA ligation. As I mentioned, pain, full bladder can be the reasons of postoperative. Take care of this. Give adequate analgesia. Top up your epidurals. Pain can be controlled with continuous intravenous analgesics. Sometimes skipped antihypertensives can result in the patient developing hypertension. See that these have been given. Intraoperatively, some of the drugs which you would like to avoid in an hypertensive patient, especially with IHT, are atropine, glycopyrrolate, ketamine, pancuronium. A good intravenous anesthesia with total intravenous anesthesia, balanced anesthesia will help the patients. Morphine is a fantastic drug. Continuous fentanyl, intermittent fentanyls will also help in prevention of the hypertension. Use monitors other than routine whenever required, and the patients should be put on non-invasive blood pressure monitoring. Go for invasive monitors when you are expecting fluid shifts and lot of blood loss. Use a capnograph and other monitors. You can use beta blockers for managing tachycardia. Use vasodilators, for treating your hypertension, phenylephrine for hypertension. See that you use narcotics intraoperatively when the patient is live, epidural in the post-operative period, and continuous IV analgesics. What are the anesthesiologist's dilemma then? You get treated patients, untreated patients, controlled, uncontrolled. How do you manage this? Whether to accept, whether to cancel, what are the acceptable blood pressures, what are the associated damage? What is the risk of proceeding with the patients when they have hypertension and you find this to be found in a pre-operative period? If you continue without treating them, you may end up with hemodynamic instability. Patients may develop left ventricular failure, can have fatal arrhythmias. Patients can develop myocardial infarction, ischemia. Patients can have cerebral hemorrhage, and there is definitely increased morbidity and mortality. My answers to some of these questions, what I put to the postgraduates, please remember that all elective surgeries should be postponed if the diastolic blood pressure is more than 110 and a systolic blood pressure is more than 108. Why you have to do this? These are the patients who are at a higher risk of ischemia, infarction, dysarrhythmia, cerebral hemorrhage, in addition to surgical bleed or vascular problems. What should be your target? Once you postpone the surgery, put them on treatment for about 4 to 6 weeks. If the patient is aged below 60, I would say that the blood pressure should be below 140/90. If they are more than 60 years, keep the blood pressure around 150/90. And in diabetics, you accept them after a treatment of 4 to 6 weeks. If in an elective procedure, a BP of 140/90, and in renal, chronic renal failure, a BP of less than 140/90. This is one thing you should remember. Not just cancel an elective procedure, but try to tell them that it requires at least 4 to 6 weeks for normalization of the autoregulation. Most of the body vitals are dependent on this autoregulation. Just giving one tablet of antihypertensive, which many of the surgeons try to do it pre-operatively by giving a dip in, the blood pressure is normal, you take up and you think that the blood pressure is fine. But the autoregulation is shifted, which can result in hypoperfusion with the fall of blood pressure. So one thing I always tell, in an emergency situation, don't reduce the blood pressures to more than plus minus 20 of your pre-operative. The mean arterial pressure recommended is about 60 millimeters of mercury. And when the mean arterial pressure falls below 55, it can result in the vitals getting lesser blood flow. Even a heart rate of more than 100, combination of this can result in myocardial ischemia and infarction. To summarize for the postgraduates, I would say that the stage 1 and 2, what I said earlier, are the stage 1. You can go ahead with elective surgery. When the blood pressure is more than 110 diastole and 180 diastole, it is always better to treat and take up. To conclude this topic, I want all the postgraduates to remember that hypertension is a disease and it is a big risk for anesthetizing. Don't take it easy. All of us have come across both hypotension and hypertension in managing a patient with hypertension. Please know about all the antihypertensive drugs, their interactions, mode of action, where they act to give a better anesthesia. Continue medications till the morning of surgery and restart as early as possible. Try to manage their pressures aggressively in the intraoperative period, because what has been recommended is a systolic pressure of 130 and a diastolic pressure of 90 should always be maintained to prevent any complication. Know your drug interactions and should not cancel a patient who comes with hypertension for reasons because it adds to the cost of the patient, cost for the hospital. He has to get admitted again. He has to come back. Have solid value reasons for you to postpone the surgery. I think I've taken about 45 minutes to try to briefly tell. This is not enough. More has to be prepared by the postgraduates. This is just a brief think what I have told in the exams, what you will be expected to answer. If you want me to discuss, I can go for another 3 hours, but the organizers have given me 40 minutes. And I thank ISA Kerala for giving me this opportunity to connect to all of you from all over the place. Thank you very much.
Thank you, sir. Thank you, sir. It is a very exhaustive, beautifully presented the topic. I think there is a lot of take-home messages for the postgraduates who are appearing for their final exam on 24th next week. Any questions in the chat box? I think there is a couple of comments and questions like anesthesia complications in LSCS for an eclampsia patient. There's a question from Dr. Nirmal Kumar Gupta, and another question, a word on hypotensive anesthesia in paranasal sinus surgeries.
Yeah, Dr. Nirmal Kumar Gupta is a gynecologist, and he's my classmate.
Okay.
He got hooked on to this. And Dr. Nirmal, if you come on this one, we are not discussing about hypertension in a pregnant patient or preeclampsia and eclampsia. It's a huge topic, which itself is a great thing. And the management of hypertension in eclampsia and preeclampsia vary because it is involving both the mother and the child. And the drugs used are different. And I think we'll have to discuss this in another session.
Yeah, that's. I thought it is. Anyway, it's welcome, Dr. Nirmal Kumar Gupta. So, any comments as a gynecologist which you would like anesthetist fraternity to hear?
Nirmal, are you there?
You can unmute and give your comments. No issues.
You must have gone for a cesarean, I think.
Yeah. And another question is, I think hypertensive anesthesia for first surgeries or paranasal sinus surgeries is another big topic.
Yeah, usually we are very happy to anesthetize these patients with dexmetadine, and I have found most of these first surgeries very comfortable with that. You are not to use any of, and especially when you get a hypertensive patient for first surgery, one thing I want to tell the postgraduates is that see that the patient, it's not an emergency surgery. See that the patient is on adequate doses of antihypertensives pre-operatively, probably with consultation with a cardiologist or a physician who's treating, may require polytherapy, get the blood pressures to normalize, and then take them up for surgery. And intraoperatively try to bring the pressures down with any of the methods. And often I use dexmetadine to reduce the heart rate. By reducing the heart rate, the blood pressure comes down and controls the bleed in these patients.
We give tranexamic acid also. Pre-operative itself, we give tranexamic acid also.
Yeah. 1 gram pre-operatively and probably 8 hourly in the post-operative period.
Your comment is well taken, because it's very difficult to, or it's very dangerous to give hypertensive anesthesia in an uncontrolled hypertensive patient for a first surgery.
Good evening, Mali sir. This is Dr. Bilal from Saudi Arabia, from Riyadh. Good evening,
nice
Dr.
to see
Rajesh.
you, Bilal.
I was the junior to Professor Mallikarjun in anesthesia during my time there. But it was a very, very nice presentation, Prof. It is very, very nice of you to remind us back of our old days. Hope you are doing fine. And,
I'm fine, Bilal.
hope to see you soon.
Nice to see you also.
Nice to meet you, and very, very good way you put it to the juniors, because those drugs are gone now. They don't even see any of those drugs which we used, and we suffered with only the non-invasive blood pressure, most probably. Now they are very lucky. They have everything, and they have teachers like you, Dr. Rajesh, and the group. They are doing a very good job by doing this. Good. And Venkat Giri also has been a leader of the ISA. Good. Congratulations to the ISA, Kerala, and all the guys there. You are doing an excellent job. And these postgraduates are really lucky. We didn't have these opportunities except face to face with Malli sir and some of our seniors, Gurraj sir, Manjunath sir. It was a pleasure to be with them, and still we miss them. Thank you very much, Malli sir. Thank you. God bless you. God bless you, Malli sir.
Thank you. Thank you.
Thank
Thank
you,
you,
sir.
Kerala.
Thank you, sir, for the comments. Another comments is another query is oral drug of choice, hypertensive crisis, late post-op.
Oral, I think in most of the hypertensive crisis, we should go for intravenous vasodilators, if you ask me, because bringing back the blood pressure as early as possible is always better in the post-operative period. Then I said, you don't want the patient to be hypertensive. You don't want the patient to be hypertensive. The recommended levels are around 70 to 90 diastolic and 130 systolic. Anything beyond that, try to bring them back with your intravenous, either beta blockers or vasodilators. Yes. I would not recommend oral medications.
Which antihypertensive to be stopped before surgery? That's another question from Jay.
I would not like to stop any antihypertensive, but as I discussed during my discussion that AC inhibitors can cause severe hypertension, there are people who want to stop it, but there are people who want to continue it, and what they do is, or they recommend is, give about 250 to 500 ml of IV fluids before inducing these patients, which may help in reducing the amount of fall of blood pressure and also keep direct acting vasopressors to manage any severe hypertension.
Hello, Malli sir. I am Harinath Sagar from Kannur.
Good evening, sir.
Good evening. I was a student. What I want to ask you is, it is hypertension during lap surgeries for a normotensive patient who has been well pre-medicated with the morphine, with all the pre-medicates available. One.
Yeah,
second
see,
thing.
Here, shall I answer it?
Yes, please.
Yeah, in all hypertensive patients, when you, in a normotensive patient, when you produce pneumoperitoneum, there are something called a stretch factor, receptors in the abdominal wall.
Yeah.
Every laparoscopy will result in the blood pressures going up initially. So you don't need to do anything other than deepening the planes of anesthesia. It is a normal response to pneumoperitoneum, and this can be exaggerated in a hypertensive patient. But as this is in the initial part of your laparoscopy, as the duration of your laparoscopy increases, there will be absorption of carbon dioxide, which is the most commonest drug which is used. For this one, this can cause hypercapnia and subsequent hypertension. So a good ventilated patients will always not have hypertension towards the end. The initial is because of stimulation of the sympathetic receptors with your pneumoperitoneum. Hope I have answered it.
Yeah, I agree to it. But since this is a postgraduate discussion, I am mainly a practicing anesthesiologist. Yeah. So I was facing all these things because I want to give a good outcome after surgery. That is an awake patient. Yeah. So what I started doing was, for normotensive patients, I started combining regional with the GA.
That is always good. Any procedure when you add regional, but even if you add regional, probably the regional technique is causing some of hypertension and not showing up this sympathetic receptor stimulation with pneumoperitoneum. Which may help in,
because it is blocked. Another question which I want to ask you is, what is the relevance? Is there any relevance in the rate pressure protect in a patient who has got a decreased EF, who is coming for regional anesthesia?
Today we don't follow this. They follow this rate pressure product, doctor, because when you have better investigations and better this one, we never follow it. So we have to go with our echo and rate pressure product, and was triple product was used in those days when we did not have all this. So please don't correlate that in your management.
Fine. Now, I want to ask you about these steel syndromes in a patient who is having decreased EF coming for surgeries, whether it is regional or general.
Okay, the steel, of course, today's topic was hypertension. I did not want to discuss much about IHD.
Yeah.
I think
okay,
Paul and others are planning to have another discussion on IHD. But
That's
still, since you have asked, steel is something which happens with, it's a misnomer. When you anesthetize the patient, we find that when you're using isoflurane, it can steal from the normal to the, from the abnormal portion to the normal, causing further reduction in the blood flow to that part which has been diseased, infected. When you use some of these drugs and when there is hypertension.
Is halothane and pancuronium still available in India?
Of course.
It is there.
Still being used in so many places.
No,
it is
I was a chronic user of halothane and pancuronium. Now their company is saying it's not there.
No, it is there.
It is there.
And for the postgraduates, they have to know everything about pancuronium as well as halothane. No excuse for that.
Just out of curiosity, I want to ask you one question. When a postgraduate comes for an examination, and if the EF is say around 30%, we come across so many cases like that. Yeah. And if the choice of anesthesia for a TURP, if he says, I will give spinal anesthesia, will he be let through or will he be detained?
No, this is what I said earlier. Probably in a discussion on TURP and anesthesia, this would have been discussed at wider length. When a patient with hypertension and IHD with a ejection fraction of 30, I will tell the PG that if there are no contraindications for general anesthesia, go ahead with general anesthesia, which is much safer than going in for regional. If at all you want to give regional, probably choose epidural anesthesia, where you can slowly increase the level of your block. See to it that you can keep the block below T10. Don't say spinal. If you are giving spinal, you can have precipitous hypertension. And especially if he's having renal disease along with this, we have much more problems with that. Patient may develop pulmonary edema within.
Sir, I've got one more. A patient with a bad EF coming for a lap cholecystectomy, is a segmental thoracic spinal accepted as an examination answer?
No, not at all. All laparoscopic anesthesia has to be under general anesthesia. Basic, that is, because you should not do even a lap sterilization under regional technique. If you are planning for anesthesia, it has to be general anesthesia, because you have a pressure on the lungs which will cause the FRC to come down. You have a pressure on the gastric which can cause regurgitation, and you are using a position which is lithotomy, which is not advisable for any laparoscopic procedure under regional technique.
Safety first, Prof. Safety first. Nothing to worry about the thing. Safety first. Be safe. The patient can recover later and manage. What Sagar is telling is his experience outside the outside. He's talking about his own experiences. Poor guy is facing so many problems. If you come to a teaching hospital like ours, we have all the, by God's grace, all of the equipment, everything. We put a echocardiography. See, my saying, as the Prof is telling, if the ejection fraction is 30, the patient is walking around, eating, doing his normal work, he is not at a very high risk. So GA is not contraindicated. Sure, GA can be given, but spinal, you should be very careful. It is a double-edged weapon. Either it will help you by coming off all the multi-drugs and things, you get single shot spinal, you finished off. But if it is going to go the other way, then you will be blamed not only in the court, but your colleagues also said, why did you use spinal? First thing they'll ask you, why not GA? So try to be as safe as possible, because with the GA, you can control your things. And also if you, by God's grace, something happens, God forbid, you will not be blamed. They will say, no, he did the correct thing. So for both the safety wise and the thing, I think better go for the easier way is the GA. where you can control things. But if it is spinal and you want to give it, you should face the music. If it goes wrong, you're ready for the music. So sometimes we try to take a shortcut, we escape. By God's grace, God is helping. Otherwise, you are in real trouble if you get stuck. So Sagar is trying to explain to us his problems when he is working alone in the private sector in a rural area. Yeah, this is definitely you should be careful and try to take as much as precautions as possible when you are doing the cases. Thank you very much. Nice seeing you, Sagar. Nice seeing you.
What you said is correct.
No contraindication for any anesthesia.
No, what you said is correct.
It has to be well managed by the anesthesiologist.
What
Sagar is looking very different.
Bilal sir said is
Nice
correct.
to see you, Sagar.
See, what Bilal sir said is correct. He's saying a person with 30% EF, if he is walking around, then he is fine. But when he is walking around, what I mean is that when you anesthetize him, we should keep the rate pressure product at that level. We should not allow the RPP to go above that. That's why I'm asking about this RPP.
That is one of the most primitive investigation we used to do. But today we never go by rate pressure product. We have to go by your exercise echoes, your exercise tolerant. You mark your this one to manage the patient.
Thank you, sir. Thank you. Nice talking to you.
One more discussion to go on.
Yeah, I hope I did not take too much time, Paul.
No, sir, you took exactly 40 minutes. Thank you very much.
I took more time, I think. Sorry.
No. It was good to see Sagar in this shape.
Yeah.
Okay, thank you. You're working in Koili only, no? Koili?
Yeah. Past 30 years.
Dr.
Nice to see you.
Professor Mallikarjuna, there is another question from Dr. Sripada. What is the impact of Propofol on BP in hypertensive patients, controlled or uncontrolled? And then second question is choice between beta blocker and nitroglycerin for controlling intraoperative hypertension.
Okay, Sripada.
And
okay. I think
sorry, one more.
Take a postgraduate, he has put the question.
Yeah.
He is a better anesthesiologist and professor. The first question was use of Propofol in a hypertensive, controlled and uncontrolled. In a controlled patient, the reactions will be much less. In an uncontrolled patient, the hypertension can be more severe, right? The second question is
sorry, the question is hypotensive patients, controlled or uncontrolled? Or
hypertensive patients?
He has written hypotensive.
No, I think he mentioned hypertensive, controlled and uncontrolled.
Okay.
Because I said in my lecture that patients who are under control will behave like a normotensive patient. The fall in blood pressure is not much. An uncontrolled patient who is given Propofol can have more labile, can have severe hypertension.
And another question is choice between beta blocker and nitroglycerin for intraoperative hypertensive crisis.
Depends on whether the patient is having tachycardia and causing hypertension, or the heart rate is fine and it's causing blood pressure. If there is tachycardia, I would prefer using a beta blocker. If there is no tachycardia, I can go for nitroglycerin.
Of course, we have to roll out a light plane of anesthesia and adequate.
Of course, after doing that, okay, I accept that.
Sorry, sir, I missed in between.
Yeah.
I missed the discussion in between.
You can go to the recording. I think you are getting late, Bilal. I'll call you. He's a professor at Riyadh University in Riyadh, Paul.
Yeah.
And the way he gives anesthesia, the way he manages things, and he's an expert in. He was one of the first ultrasound using. He used to come to India just to demonstrate ultrasound.
No, sir, all your Ashirwada, sir. All your Ashirwada, sir. Nothing.
Anyhow, Bilal, we'll talk up. I think we should not.
Sure, sir. Sure. It was very nice. Thanks to the ISA Kerala for giving me a chance to speak. Thank you so much. Thank you so much.
Your name is written as Mohammed Delvi, and he's calling you
Bilal. My name is Mohammed Bilal Delvi, the whole name. The British and the Americans use only the first name and the last name. So they think my first name is Muhammad. My name is Muhammad Bilal together. So Delvi is my family name. So
Nice
this
to have
Zoom
somebody
thinks
from
I am Muhammad Delvi.
overseas
They
also
left
here.
the middle name. So Prof knows me as Bilal, not Muhammad Delvi.
Okay.
And another question from Dr. Kiran Gera: how much dexmedetomidine can be used? We can give. I think it was in the context of FES surgeries. It's not, Dr. Kiran Gera, you can unmute and ask the question directly. Is it in the context of endoscopic surgeries? FES?
For prevention of hypertension during intubation.
The question is not clear.
Yeah, for prevention of this one, it is about 25 micrograms, about 45 seconds before. And for FES, I give about 50 IV start and then incremental dose, or put it in an IV drip and maintain the heart rate.
It's in the context of lap surgeries that he has explained.
Laparoscopic surgery.
Thank you, sir. It was a nice discussion also. Can we go to the next session?
Rajesh,
yeah. Dr. Murali is there.
Which is the choice of beta blocker intraoperatively? It's labetalol or metoprolol?
Or even you have esmolol also.
Esmolol.
Go for esmolol. Labetalol maybe in eclamptic, pre-eclamptic patients.
Esmolol is a good choice, but the problem is it may not be available easily.
Yeah.
Esmolol.
Most of the places it's available.
It's available.
The thing is that we should put it in infusion and it's little costly.
Yeah, that's all.
Can give bolus also.
Available.
Metoprolol, the problem is that it just got long-acting drug, and you have to be very careful with its use. Thank you, sir. Over to Dr. Vijesh.
Yeah. Good evening.
Thank you, sir. Thank you very much, Mallikarjuna sir, for the nice discussion and also for the interesting talk.
Thank you, everybody. I should thank the ISA Kerala, the President and Secretary, Shamshad and Paul.
Okay,
thank you very much. If you permit me, I will go for my case.
Thank you, sir.
Okay.
Thank you very much.
Very late. Yeah?
No, some of my surgeons said, okay, you finish and come.
Okay.
So we can pass on to the next
on
one,
Vijesh.
Thank you very
move
much,
on
sir.
to the next final session of the day, and that's the PG corner, where we have postgraduate students presenting a drug and an equipment with the PG update sessions that we conduct. And this time we have postgraduates from Government Medical College Thrissur who will be presenting on Propofol and IGEL. So over to Dr. TJ Kannan to present on Propofol. Dr. Kannan, you're there?
Yes, sir. So I'll share my screen.
Yeah, sure.
And then put
Slide.
Yes,
You can make it into slideshow.
okay, sir. So I'm audible, sir?
Yeah, audible, and your slide is visible also.
Okay, sir. So for today's segment, we'll be dealing with the drug that has become very much popular and quite inseparable from our day-to-day practice of anesthesia. And yes, the drug is Propofol. And we'll deal with Propofol under the following headings. So to begin with, Propofol is the most widely used anesthetic agent. It has its origin as ICI 35868 in 1970s in UK by the Imperial Chemical Industries. It was in 1977 that Kay and Rowley, they confirmed the ability of Propofol that it can be used as an inducing agent. However, what happened was that there were a lot many reports of anaphylaxis, but this was because of the vehicle that was Cremophor EL. So later this was withdrawn and reformulated and introduced as an emulsion, which was launched in 1986, and it received the FDA approval in 1989. So coming to the physicochemical characteristics. So what is it? So this propofol, it's a non-barbiturate, short-acting intravenous anesthetic agent. Structurally, going back to and the structure, we see we have the phenolic ring over here, and at the second and at the sixth position we have the isopropyl side chain. So structurally it's a 2,6 diisopropyl phenol, which is a highly lipid soluble and insoluble in water. It is viscous and it's milky white. And why is it milky white? Is because of in this emulsion, the particles, they scatter the whole spectrum of light because of the Tyndall effect, and thereby imparting it a milky white color. It is isotonic with a pH of 6 to 8.5. This pH is very much vital for the stability of the emulsion. It's stable at room temperature. It is not light sensitive. It can be diluted with 5% dextrose and RL up to a dilution of 2 mg per ml, and it is stored between 4 to 25 degrees centigrade. It's available as 10, 20, and 50 ml vials, 20 ml ampoules, and 100 ml bottle. And it's also seen in a pre-filled syringe form. You can see the Diprivan syringe over here. Now, what does it contain? So there have been many development and research that has been gone over the years to result the solution, the emulsion that we use now. So 1 ml of solution, we have the drug Propofol, 1%. We had 2 emulsifiers, namely the soybean oil over here and the purified egg lecithin at a concentration of 10 and 1.2% respectively. Glycerol at 2.25% is a tonicity adjusting agent, and we have sodium hydroxide to change the pH. Propofol, the lipid, it's an excellent culture medium. So there arose a need for addition of bactericidal agents, and we have commonly used, we have the EDTA in a concentration of 0.005. And a very important practical point that is to be noted is that once Propofol is opened, after 6 hours, it must be discarded. Mechanism. Propofol is a GABA mimetic with direct and indirect actions. So Propofol, it increases the transmembrane chloride conduction, thereby resulting in a hyperpolarization of the postnatal cell membrane, thereby the functional inhibition. Also, it inhibits the NMDA receptors to the sodium channel. A few more points when it comes to the mechanism of action is it inhibits the acetylcholine release in hippocampus and prefrontal cortex. It increases the dopamine concentration in nucleus accumbens. So there is a sense of well-being, and it is just this single fact that has resulted in Propofol being a drug of abuse. And also tolerance developed to Propofol, and so there is a higher chance with every subsequent use that the abuser falls on to even greater complications. Propofol has an anti-emetic effect due to its action by decreasing serotonin levels in the area postrema through the action of GABA receptors. At a dosage of 10 to 20 mg, which can be repeated every 5 to 10 minutes, or we can start an infusion at 10 microgram per kg per minute. Antipruritic effect is because of its action on the medullary dorsal horn transmission, with inhibitory effects seen on the cyclooxygenase enzyme. The dosage is 10 mg IV, and this is very much effective in the treatment of pruritus that is seen with neuraxial opioids or cholelithiasis. With a molecular weight of 178.27 Dalton and a pK of 11, it is a weak acid. The volume of distribution is quite high with 2 to 10 liters per kg, and the clearance is 1.5 to 2.2 liters. What about the clearance? If we see the clearance, we can note that this value is much higher than the hepatic blood flow, which is between 0.8 to 1.2 liters. So what does that imply? It implies that there are other sites through which Propofol is getting cleared of. And yes, we have the kidneys and the lungs in the clearance of Propofol, each having up to 30%. A highly protein-bound drug with 95 to 98%, the distribution can be described by 2-compartment and 3-compartment models. So we are infusing, we are giving a bolus of propofol. What happens? So there is a rapid equilibrium that is being seen between the plasma and the brain, and this would give a rapid onset of anesthesia. So the phase one, what happens is that once we give the drug, this is rapidly distributed to the highly perfused organs, such as the heart, the kidneys, the lungs, and liver. And what happens is that there is a decrease in concentration and there will be a rapid awakening. So the T-half at this juncture is 1 to 8 minutes. Next, what happens? There is drug in the highly perfused organs, so this would in turn get redistributed. So phase 2 is the phase of redistribution into the muscle and the adipose tissue with a half-life of 30 to 16 minutes. Finally, the terminal elimination, the half-life is 4 to 24 hours, and what happens is that there is a very slow release from the deep compartment with limited perfusion to the plasma, and thereby it gets metabolized. Coming to the levels that is required during surgery is 2 to 5 microgram per ml, and it must be less than 1.5 microgram per ml for the patient to awaken. And the required decrease in concentration for awakening is less than 50%. And the golden point when it comes to propofol is that the recovery remains rapid even after prolonged infusions. That is, even if you keep propofol for up to 8 hours, the context-sensitive half-life is less than 40 minutes. The context in this context-sensitive half-life being the duration of infusion of the drug. After a bolus dose of 2.5 mg per kg of propofol, the onset of hypnosis is rapid, that is 1 brain arm circulation time, with that reaching the peak effect by 90 to 100 seconds. It's rapidly metabolized in liver. It is oxidized to 1,4-diisopropyl 1,4-quinol, which is inactive. Later, this is conjugated with glucuronic acid, thereby releasing water-soluble compounds excreted by the kidney. And these quinols, the carbols, that can impart a distinct healthy green tinge to urine. So this is quite usually seen in ICU patients who had received prolonged infusions of propofol, and this green urine can, of course, create a lot of confusion. Propofol, almost less than 1% and 2% are excreted unchanged in urine and feces respectively. And of course, as I have mentioned earlier, we have the extrahepatic metabolism by the lungs and the kidneys up to 30%. Pharmacodynamics, central nervous system, there is a dose-dependent depression of the cerebral cortex, ascending RAS and the medullary center, thereby having sedation, hypnosis, amnesia, anesthesia, and respiratory depression. The CMRO2 is decreased, so there is decrease seen in the cerebral blood flow, ICP, and CPP. And with a dose of greater than 1 mg per kg body weight, it decreases the seizure duration. Coming to seizure, one peculiar action or what is seen with propofol is that it can either induce seizure or it can suppress seizure. The triad of the GABA mimetic action and the NMDA inhibition and also the modulation of calcium channels can suppress seizures. However, the same thing, that is the agonism of GABA plus the antagonism of the glycine can, it can induce seizures. So that is one thing with propofol. And propofol decreases the sympathetic activity greater than the parasympathetic system. Propofol causes a dose-dependent respiratory depression with apnea seen in up to 25 to 30% of patients. There is decreased sensitivity of the respiratory center to increase carbon dioxide and hypoxia via the carotid body chemoreceptors. There is depressed laryngeal and cough reflection, and this point is a boon, especially when it comes to the introduction of the supraglottic airway devices. Propofol is a bronchodilator and it potentiates hypoxic pulmonary vasoconstriction by the inhibition of potassium ATP-mediated pulmonary vasoconstriction. Cardiovascular system. Whenever we are going to induce a patient with propofol, the first thought that strikes your mind is how much the BP is going to fall. Yes, the most prominent effect is the decrease in arterial BP, with the systolic BP falling up to 25 to 40%, with similar changes being noted in the diastolic and the mean arterial pressure. Why does this happen? This is because of the vasodilation and the direct myocardial depressant effect. Cardiac output is also decreased because there is a decrease in the sympathetic drive to the heart, with decrease seen up to 10 to 30%, and the SVR decreases by 15 to 25%. What about the heart rate? There is no significant change that is seen. Even though we think there is hypertension and there must be a reflex tachycardia, that will not happen because the reflex, the baroreflex, is inhibited. Propofol has minimal direct effects on the SA node and AV nodal function. It attenuates the heart response to atropine in a dose-dependent manner and also suppresses atrial tachycardias. The blood flow in the liver is decreased, so in a way Propofol decreases its own elimination. What about in kidneys? There is a decrease in renal blood flow in GFR because of the constriction of the splenic and the renal blood vessels. Of course, in addition to carbonuria, there can be a cloudy urine, which is because of the increased uric acid content. There is no direct effect that is being seen in the gastrointestinal system, but of course, there are adversities which we'll see later. Neuromuscular junction, even though there is a minimal or almost nil muscle relaxation, but we can get good intubating conditions with propofol use alone. There's a decrease in intraocular pressure by 30 to 40%, and this is a vital point, especially in propofol is a good agent when it comes to surgeries that involve in open globe surgeries. OBG, propofol is a category B drug with no effects in the uterine muscle tone. It closes placenta with equilibrium between the mother and the fetus being reached between 2 to 3 minutes, the FM ratio being between 0.65 and 0.85. And if we compare with thiopentone, what we can see is that the 1 minute and the 5 minute EBGA scores are low. Other properties, propofol does not trigger malignant hyperthermia, does not depress cortisol synthesis. It has antioxidant properties like vitamin E, so we can use it in acute lung injuries, antipyretic if it has been discussed, and it does not alter coagulation. Uses, first and foremost, the induction of anesthesia with a dose of 1 to 2.5 mg per kg IV. When it comes to older patients, of course, you have to modulate the dose. With pre-med, it's 1 mg per kg, and without pre-med, it's 1.75 mg per kg. However, in older and sicker patients, these patients are at the high risk of profound hypertension following propofol dose. So we must be careful. We must always ensure that these patients are adequately volume filled, and we must give them in careful incremental titrated doses. In children, the dose is a bit higher owing to their higher volume distribution, and this is this one single point that will keep this pediatric population at the risk of PRIS. That is, we'll see that in the subsequent slides. Maintenance of anesthesia with boluses of 10 to 40 mg repeated every few minutes, so we can keep a continuous infusion of 50 to 150 microgram per kg per minute when combined with nitrous or an opiate. And propofol, it is becoming very much popular in TIVA, either as a sole agent or in combination with other drugs such as remifentanil, fentanyl, and ketamine. Sedation in surgical procedures of shorter duration and also in patients who require mechanical ventilation. The infusion rates, the dosage is 30 to 60 microgram per kg per minute, but never ever more than 60 microgram per kg per minute. And one novelty over here is sedations. And what is sedation? It's a computer-assisted personalized sedation of CAPS that is being used in upper GI scopy and also in colonoscopy. Advantages. This single slide with 12 points. This is kind of a summary or a recapitulation of what we have been seeing. And this is why propofol is the very popular drug, and it shall remain so for a reasonable time for future. A rapid induction that is pleasant and smooth. There is abolition of the cough and laryngeal reflexes, quicker and complete recovery of the psychomotor function. The patients are like they are just arising from a refreshing sleep. There is absence of a stage of delirium. The depth of anesthesia can be increased rapidly, so we can easily modulate the depth. And this point is especially important when it comes to surgeries such as awake craniotomy. Less PONV, a short contact sensitivity half-life. It blunts the stress response to laryngoscopy. So always make sure you have a bolus dose ready in your hand just before laryngoscopy. It has antioxidant properties, amnestic properties, does not trigger malignant hyperthermia, nor does it influence the secretion of cortisol. Adversities. The commonest one, and the one single point for which there are so many formulations that are being tested, is the pain on injection. How to decrease that? You can either dilute the drug, Or so there are, you can always anesthetize the vein by giving xylocaine. Some literature, they suggest mixing xylocaine and propofol, but that is not recommended because owing to the change in pH, what happens is that the fat droplets will coalesce together, and we have a risk of pulmonary embolism. Systemic, the anaphylaxis can occur rarely to any of the component of the solution. And one clinical point when it comes to anaphylaxis is that during PAC, once we ask the history, there might be patients who say that they're allergic to egg. So should you give propofol or should you not give propofol? So what happens is that these individuals, they are more allergic to the egg white, the albumin. However, in propofol, the lecithin is from the egg yolk, the phosphatide. So the chances of a cross-reaction are unlikely, but however, what will be the case, we must always exercise due caution, and we can even try for a drug allergy test prior to the surgery. CNS perioperative myoclonus, hallucinations, sexual fantasies, convulsions, sophistostosis, and of course, the abuse potential with increasing tolerance to the drug, thereby having hazardous effects. Hypertension, bradycarditis, saline, CVS, apnea and respiratory system, and of course, it's a very good medium for bacterial growth. These organisms have been isolated from the use vials and syringes of propofol, and the patients are at a risk of sepsis, E. coli, Pseudomonas aeruginosa, and also Staph aureus. And one point when it comes to GIT, there have been reports of unexplained postoperative pancreatitis. Now, propofol infusion syndrome. What is that? PRIS. It's a rare but fatal syndrome usually seen in the pediatrics subpopulation. Why? Because it's this subset of people who receive propofol at a higher dose, 4 mg per kg per hour for 48 hours or longer. So in our clinical practice, in ICU, if you see an average size patient of say 50 kg, and that patient is receiving propofol at 20 ml per hour, it must be a red flag. And if this patient might have a risk of ending up in PRIS. PRIS, it's described as acute bradycardia progressing to asystole in presence of one or more of metabolic acidosis, rhabdomyolysis, hyperlipidemia, or an enlarged liver. The pathophysiology is controversial, but it is postulated that the ETS, the electron transport system, is getting deranged, thereby with the release of toxins, and also the cells are switched on to anaerobic metabolism. So there is anaerobosis, there is lactic acidosis, and super added onto that, we have the huge influx of the lipids in the circulation. Other features include cardiomyopathy, acute cardiac failure, skeletal myopathy, hyperkalemia, hepatomegaly, and lipidemia. Predisposing factors: severe cerebral injury, sepsis, poor oxygen, and of course a large dosage of propofol. What will we do? First and foremost, stop propofol. Meanwhile, think of alternative sedatives. The next, everything in the system is deranged. So there must be an active intervention and active supportive measures that we should give from our side. Cardiovascular, we must use vasopressin as an inotrope, and especially its bradycardia. And if that is refractory to all other medications, we can consider cardiac pacing. And of course, as we have mentioned, there is a huge influx of lipids. To deal with that, we can go for hemodialysis and hemofiltration. And for combined respiratory and circulatory support, we can go for ECMO. What about the commercial preparations of propofol? There are so many preparations that we are taking. Diprivan is a common one, and in our institute we are using Fresofol, and even in that there's a slight modification. The soybean oil, it's 50 mg, and of course we have addition of medium chain triglycerides and also oleic acid. What about Ampofol and Propofol? These drugs, what we have is what they are trying to do is to make propofol much miscible in aqueous solutions. So it's either succinate groups or phosphate groups are added, but even then there is pain on injection, and we don't have much data, especially with propofol. And of course, there are peculiar side effects such as perineal paresthesia that is seen with propofol usage. Non-lipid formulations that are being tested, these include cyclodextrin polymers. So what happens is that these polymers have propofol at its core, and once that is inside the vascular compartment, it is released. And that's the commercial preparations. Ending the presentation, my references were Miller and Stoltings, and that's Propofol. Thank you. Thank you so much.
Thank you, Dr. Kannan, for that excellent presentation.
Thank you,
Over to Shamshad, madam.
Yes, almost completely covered almost all. And one thing that I have to ask is, what is the role of this EDTA in the preparation of Propofol? Kannan?
Yes,
can you?
Madam, that is since the Propofol, it is the vehicle for Propofol is the lipid emulsion. But the problem is this is an excellent medium for growth. And of course, there had been these organisms, E. coli, Staph aureus, Pseudomonas, all of them has been isolated from these cultures. And of course, there have been reports of patients ending up in sepsis. So EDTA, so there arose a need for addition of this antimicrobials. So EDTA is a bacteriostatic that is commonly being used, but ma'am, there are also other bactericidal agents such as sodium metabisulfate, which is seen in some formulations of Propofol. But the issues with sodium metabisulfate are two. Number one is that sodium metabisulfate, for that to have its optimum action, it must be at a lower pH. But what happens when the pH is lowered is that the emulsions get the emulsion becomes unstable. Hello, madam. Hello, ma'am. With that, the infusions, so what the emulsion becomes, what you can say, unstable, and there's a risk of embolism. Moreover, with sodium metabisulfate, it has a bronchoconstrictive action. So what happens is that if we are giving to, even though Propofol is a bronchodilator, when we give it to asthmatics, there's a risk just because of the sodium metabisulfate.
Any role for EEG?
Ma'am, yes, ma'am. Once Propofol is given, there is a change. That is, we have the alpha rhythm first, which changes on to gamma rhythm, and finally ending up in a theta rhythm. The change in EEG by
so
Propofol.
the EEG can be used. Okay.
Yes,
okay, Kannan, you nicely presented. Any other questions? Vijesh?
And there are two questions in the chat box.
Okay.
One is about arterial injection of Propofol, inadvertent arterial injection. How would we go about it?
It's more commonly seen with hypertension, but as in the case, sure, ma'am.
Yes, because when we say about thiophanate sodium, it can cause the block, as well as it's very a serious issue. That is, when we talk about the intraarterial injection of thiophanate sodium because of the active precipitation. But it is not that recommended in Propofol, and in any of the textbooks, the intraarterial is never written. The same thing may happen with the Propofol also, because both are producing the same, but Propofol is having a much lesser pH when we compare it to the thiophanate sodium.
There are very few
Other
cases.
Explanation?
Yeah, no, there are very few cases about this one, but the cause of pain is the stimulation of the wasabi receptors on the vein. The T, that is some
IV injection.
Yeah, for IV injection. Then there is a question on ketofol. So just a few words on ketofol. Kannan can.
Sir, it is a combination of ketamine and Propofol. That is ketamine 1 ml that is being diluted to 10 ml with Propofol, and that is also being used because we have the actions of we'll get the combined actions of ketamine and also the Propofol. We have because of ketamine, it's more of a sympathetic action. There is less change that is being noted with the hemodynamics. And also we have the analgesic part, and ketamine is an excellent analgesic, so that would also get covered. While the other actions is being covered with Propofol. So that's ketofol.
Yeah, ketofol, you use it in 1:1 ratio? You can use it in 1:1 ratio.
Okay, sir. Okay, sir.
And then you could say something about Michael Jackson also, because you have talked about
Yes, so that's one noted celebrity in which it's just because of him that Propofol might have just become much more common. The name has become much more common to the general population. So that is one drug. When it comes
Propofol is now very familiar to the general
And at the end, also because of that.
Yes, sir. Yes, ma'am.
Jackson.
And thank you, Dr. Kannan. It was an excellent presentation.
Thank you, sir. Thank you so much, sir. Thank you.
Ma'am, anything else?
You have done well. Yeah.
Thank you, ma'am. Thank you.
Okay. Yes, we can go to the next session. Vijesh?
Yeah. So we wind up this session, and thank you, Dr. Kannan. We move on to our next topic, that is IGEL, and that will be delivered by Dr. Irfana Hamid from Government Medical College, Thrissur. Over to Dr. Irfana. Could you share your presentation?
Yes, sir.
Go to the slideshow and start your presentation.
Is it visible, sir?
It's visible.
Yes,
You're
yes.
audible. Yeah. Carry on.
Good evening, everyone. Every management is an integral part of our daily airway practice of anesthesia. And hence, today we'll be discussing a revolutionary invention in the field of that is common.
There is one more device which is on. Are you sitting with him? Can you ask him to stop it? Because echoing, it is echoing. If you are in the same room.
Kannan,
Yes,
please
sir.
switch off your one.
Yeah, you
Device.
just have to mute your device. That's it.
Yes, mute your device.
Yeah, carry on, Irfana.
Good evening, everyone. Every management is an integral part of our daily practice of anesthesia. And today we'll be discussing about a revolutionary invention.
Kannan is not muted, so still there is an echo.
Sir.
Please mute Kannan. Yeah, now carry on. Irfana, please. Yeah.
Today we'll be discussing about a revolutionary invention in this field of, that is IGEL. I'll be discussing it under the following contents, that is introduction, history, indication, contraindication, technical description about IGEL, insertion technique, advantages and disadvantages. Into the introduction, IGEL is an anatomically pre-shaped supraglottic airway device. Supraglottic airway devices are those airways that are intended to open, secure, and seal the supraglottic area to provide an unobstructed airway. It is used in spontaneously breathing or ventilated patients, typically during anesthetic procedures. Supraglottic airways are divided into first generation and second generation based upon their evolution. First generation supraglottic airways are those that are just simple airway tubes with lower seal pressures like our classical LMA or flexible LMA, etc. Now, second generation supraglottic airway devices are those that have an inbuilt manufacturing facility to reduce the risk of aspiration. And that is, they have a drain tube to reduce the risk of aspiration. Other features of second generation supraglottic airway devices are they have got a higher seal pressures to enable controlled ventilation at high airway pressures. And they also have got an integral bite block to protect the patient's airway against occlusion. Now, IGEL is a second generation supraglottic airway device. Other examples of second generation supraglottic airway devices are we have the BASCA mask, then we have the LMA ProSeal, we have the laryngeal tube suction, the LMA Supreme, and Ambora Gain, etc. Now, about a brief history about IGEL. The first supraglottic airway, that is a classic laryngeal mask airway, was invented by Dr. R.C. Brain in 1982. Since then, many revolutionary inventions have been taking place in this field, and many studies have been going. And one such revolutionary invention was by Dr. Mohammad Aslam Nasir, that is the IGEL, which he invented in cooperation with the Intersurgical Limited, which is located in Wokingham, United Kingdom. And it was invented after 19 years of research work, and it was later marketed in 2007. It is said that almost 35 different prototypes had been tested before the final product was launched. About the indication of IGEL, it is used to secure and maintain a patent airway during general anesthesia and elective surgical cases. It is used in both anticipated and unanticipated difficult airway to allow ventilation in case of a difficult mask ventilation or intubation. And it can also be used to secure airway during cardiopulmonary resuscitation. IGEL, it can be easily inserted, and also it can be inserted by clinical or a non-clinical staff because it requires very minimal training. So it plays an important role in emergency airway management. However, there are some contraindications to IGEL. That is, it is contraindicated in patients with increased risk of aspiration. That is, who are having an inadequate duration of fasting, or those with history of GERD, gastroparesis as in diabetes mellitus, a morbidly obese patient, or pregnant females. Now, if ventilated with high pressure, it can lead to gastric insufflation and it can predispose to regurgitation of the gastric contents. The technical description of IGEL is that it is made up of a medical grade thermoplastic elastomer gel, styrene, ethylene, butadiene, styrene. And it is called IGEL because of the soft gel-like material from which it is made. This picture here shows the sizing guidelines of IGEL. So proper insertion of IGEL, it is very essential to choose this IGEL, the correct size of IGEL. So there are different sizes for IGEL. For a neonate of size 1, we have to use, for a neonate of weight 2 to 5 kg, we have to use a size of 1. For infants with size 5 to 12 kg, we can use a size of 1.5. For small pediatric with 10 to 25 kg, we can use a size of 2. If the pediatric patient is 25 to 35 kg, we may require a size of 2.5. And in case of adults with 30 to 60 kg, we'll have to use a size of 3. And for an adult with 50 to 90 kg, we'll have to use a size of 4. And in case of a large adult with 90 plus kg, we'll have to use a larger size of 5. Now, these IGELs, as I've shown in the picture, are actually color-coded also based upon their sizes. Now, into the parts of IGEL. First of all, there is a soft, non-inflatable cuff. Then there is an epiglottic rest. Then this is a buccal cavity stabilizer. And then we can see the most important thing, the gastric channel that is running along the entire length of the IGEL. And then there is a 15mm connected tube that extends downwards to form the integral bite block. And at the proximal end of the stem, we have the depth mark, the horizontal black mark. Into the details of different parts, first of all, the non-inflatable soft cuff. This is designed anatomically to fit the pharyngeal and laryngeal and the perilaryngeal structure. So when we insert the IGEL, the non-inflatable cuff will fit snugly onto the perilaryngeal framework, and it will mirror the image of our epiglottis, the aryepiglottic fold, and the remaining structures around the perilaryngeal area. It is made up of a unique soft gel-like material, allowing the ease of insertion and hence a reduced incidence of trauma. Then the epiglottic rest. This is the epiglottic rest. It is situated at the proximal end of the mask. It prevents obstruction of the ventilation aperture by a downfolded epiglottis. Now, this epiglottic rest, when the IGEL is inserted, it will be located at the base of the tongue. So it will prevent the upward displacement of the IGEL. Then we have the buccal cavity stabilizer. This is the buccal cavity stabilizer. This is a semi-rigid, a wide stem which is elliptical in shape. It is curved in cross-section and it is large caliber. So this lessens the likelihood of displacement or axial rotation after insertion. Then the integrated gastric channel. This helps to reduce the risk of aspiration. This gastric channel will allow the passage of nasogastric tube through the channel. For example, for an IGEL of size 3, 4, 5, we can easily pass a nasogastric tube of 12, 12 and 14 respectively. The airway tube, as I mentioned, it has a wide bore. It ends in a large ventilation orifice with no bars or gills. And at the distal end of the stem, there is a 15mm connected tube to which the anesthetic circuit is later connected. This connected tube extends into the airway far enough to provide an integral bite block. This is rigid and it is non-compressible. And then in the proximal end, as I showed, there is a horizontal mark, that is a depth mark, which is a guide to the approximate, the correct depth of insertion of the device. Now into the pre-insertion preparation of iGel. iGel is available in a sterile pouch enclosed in a protective cradle or a cage bag as in pediatric iGel. Now, these cradles are color-coded and they also help to maintain the stem's preformed curve. So first of all, it is very essential to choose the correct size of the iGel depending upon the weight of the patient. After that, the device should be properly checked for any defects or any obstruction. Then we have to lubricate the back and side of the mask with a thin layer of water-soluble lubricant immediately before use. And then the iGel should be separated from the cradle before insertion. We should never use a cradle as an introducer. About the insertion technique, first and foremost, we have to ensure an adequate depth of anesthesia before insertion for a successful insertion of iGel. We have to extend the patient's head. We have to flex the neck gently, that is sniffing the morning air position. After the chin is pressed down gently by the assistant, and then we have to introduce the iGel with the concavity facing towards downwards towards the chin. Here, this picture, it shows how the correct insertion of an iGel. The head is extended, neck is flexed. The assistant is pressing down the chin gently. And then the iGel is held in the dominant hands between the thumb, index, and middle finger. And we have to hold it with the concavity facing downwards towards the chin. And then the iGel is introduced, or it is glided along the hard palate, soft palate, or the posterior pharyngeal wall till a definite resistance is felt. And at that time, when it is correctly placed, the cuff will be placed in the perilaryngeal area. And the horizontal black mark that I showed before, it should coincide with the patient's incisor teeth. Now, after insertion, the iGel will get automatically sealed to the surrounding perilaryngeal airway, which gives it an advantage over other supraglottic airways. This is the picture showing a correct insertion of the iGel. Here, the tip of the airway should be located in the upper esophageal opening, that is the point A. The cuff should be located against a laryngeal framework, that is the point B. And the point C, the incisors, should be resting on the integral bite block. Now, sometimes we may encounter certain difficulties while insertion of iGel, and during these circumstances, applying a jaw thrust can facilitate with insertion, or we can use a rotatory technique. That is, the device is inserted laterally, and then it is rotated into place as resistance is felt on reaching the posterior pharyngeal wall. Or we can use a reverse inversion technique. That is the way how we insert a Goodell's airway. The iGel is inserted with concavity facing towards the hard palate, and then it is rotated 180 degrees on reaching the oropharynx. Now, after insertion, after confirming the correct depth of insertion, the iGel is secured with tape from maxilla to maxilla. The anesthetic circuit is attached to the 15 millimeter connector, and the ease of ventilation is confirmed with gentle manual ventilation. The pharyngeal seal is, in most cases, is approximately 20 to 30 centimeters of water. Now, this iGel, it has got, as I mentioned, an airway tube which has a wide bore with the ventilation orifice does not have any bars or gills. So it can serve as a conduit for endotracheal intubation in adults. However, study shows that better results have been obtained with fiber optic guided intubation rather than blind intubation. And again, iGel is latex free and it does not contain any metal parts. So it's safe to use in patients undergoing general anesthesia for MRI. Now, about the removal of the iGel, it is removed once the patient is awake or easily arousable with verbal commands and protective reflexes are present. So we have to give a gentle suction of the oral cavity and pharynx prior to removal. However, if the patient has got a hyperactive airway, like smokers, asthmatics, COPDs, it is better to remove in a deeper plane of anesthesia. Now, we'll see some of the advantages of iGel over face mask. First of all, it provides a more secure and reliable means of ventilation. And when we insert the iGel, the mandible may not be supported. So the anesthetic's hands do not fatigue, they're free. And again, the speed and placement, the speed and ease of placement, that requires minimal training. So it can be easily learned by a clinical, non-clinical staff, and it is an important, it can be easily inserted. It can be used in patients with abnormal facial contour, provided the mouth opening is adequate for the supraglottic airway insertion. Again, when compared to face mask, there is a lower risk of aspiration. Now, when we compare it with endotracheal tube, Again, as I said, the ease and speed of placement of igel, because igel insertion does not require a direct visualization of larynx. And there is also a better hemodynamic stability during the insertion and removal of igel when compared to laryngoscopy and intubation. And there is also minimal intraocular pressure and intracranial pressure changes. And most of the time, we do not require a neuromuscular blockade for insertion of the igel. And again, it has got a non-inflatable cuff, so there is a reduced incidence of trauma to the airway structures. To conclude, igel is a pre-shaped second-generation supraglottic airway device. It accurately positions itself over the laryngeal framework, providing a reliable perilaryngeal seal. And it has got a non-inflatable cuff, which is made up of a soft gel-like material, allowing the ease of insertion and reduced trauma. And it is designed for providing anesthesia with spontaneous and controlled ventilation. And it is contraindicated in patients with increased risk of aspiration. These are my references. Thank you.
Thank you, Irfana. It was a nice presentation on igel. What are the advantages of igel, or have you seen any difference between an igel and then comparing the different types of supraglottic airway devices? Like any advantage igel has over LMA?
Sir, when igel is inserted, it gets automatically sealed to the surrounding perilaryngeal airway. And when we look at LMA, it does not have an classical LMA. It does not have an integral bite block. And again, when we compare it to the first generation, there is gastric channel, so there is reduced risk of aspiration.
Right. Madam, any comments from your end? Shamshad, madam. You have to unmute. You're on mute.
Anna, the shape of almost the igel as well as the kappa mask is almost the same. So can you make the differences between these two? Kappa mask, even though it is not available to us, but from the picture and all, we are seeing that when we see, it is very difficult for us to differentiate between kappa mask as well as igel.
Madam, when it is inserted, the kappa mask, when it is Basca mask, when it is inserted, the tip will go into the esophagus. And again, so the distal part has got a large aperture, which is in continuity with the gastric or the drain tube. So there'll be an easier drainage of the gastric fluid when compared to the igel.
Yes,
and it also,
the drainage tube that is directly going into the esophagus, so that the protection will be much better with the kappa mask.
Yeah.
Okay, we compare it with the igel, and the igel is automatically fixed to the perilaryngeal area because of its nature of the substance that it is made. Okay.
Yes.
Any more questions, Vijesh?
Well, ma'am, the same advantage of igel over Basca mask. Then what is the advantage of igel over LMA? These were the questions in the chat box. Can we use igel during ECT?
Yes, definitely.
And
what you have asked is during ECT.
Yeah, during ECT, can we use an igel?
Yes.
Another thing is use of igel as a rescue airway, which I think was already been mentioned.
Yes, so all this we can use it. Because in our hospital, ECT is not at all done. And it's better to use when we compare it with the mask, face mask, igel can be used.
It means that no ECT is done under anesthesia, or it's direct ECT in your hospital?
No ECT is done under anesthesia, and the number of incidences of ECT is very less. And I don't think there's PGs have seen ECT under anesthesia. Irfana, have you seen?
I think last year, maybe a year before that, the question was on modified ECT.
Yes, the question is there, but I don't think the psychiatrists are recommending ECT. under anesthesia or a modified ECT, and they were not at all recommending the ECT nowadays. But when I was in Manjeri, they were doing it minimum 3 to 4 per day. But here they were not using. They're not at all doing.
There's another question in the chat box, ma'am. How to do controlled ventilation with IGL?
Yes. Irfana, can you answer?
So controlled ventilation with IGL is after induction, if the insertion is induction with an inducing agent, and if the insertion is difficult, we can give a depolarizing muscle relaxant. And after insertion of IGL, after confirming the proper position that is inserted by the auscultation method, by looking at the chest rise, and also by capnography, we can use we can continue with our ventilation procedure. That is, we can like how we do with the endotracheal tube, we can continue with that, provided the duration of the surgery is short. That is, we cannot do it for a prolonged duration of surgery.
Dr. Irfana, can we use it repeatedly, IGL?
Sir, IGL is actually a single-use device, but in developing countries in hospitals, they are using it after sterilization. They keep it in soda bicarbonate solution, and then with washing it with soap and water solution, they sterilize it with formalin solution.
What is the disadvantage on reusing?
The property of the cuff will be decreased, sir, the thermoelastic property.
Dr. Irfan, what's the problem with all these supraglottic airway devices in general? Any infective complications described? It's a very rare neurological condition. Rare condition which is described reported less in India, but more commonly in the West. Have you heard of prion body contamination?
Yes, sir.
Yes, sir. So there is a rethink about all these repeated use of supraglottic airway devices. It's all these devices okay for single use, but for a country like ours, not sure whether we can afford to. So prion body contamination is not much described or rather reported in India, but it's a well documented entity. Okay.
Okay, sir.
It's not only with IGL, but with all other supraglottic airway devices. Anyway, both of you presented well. And congratulations for both of you and your faculties who have shaped you.
Thank you, sir.
Right.
There are no more it's a long day, or rather a long night that you have spent today. Over to
Saturday night also.
Paul and Shamshad madam for the final.
The difference that we have seen today is we have got so many of the discussions after each and every presentation. That's why the time has extended. Otherwise, we are planning it up to stop up to by 8:30.
And also we had one from overseas, Dr. Bilal. It was nice to hear from him.
Sorry, I took your time. Sorry, I interrupted.
No, not at all. Not at all.
Sir, you are very welcome. Welcome at any time. You can enter into our discussion.
Thank you so much. Hope to do a session with all of you again. Hopefully. Thank you so much. Thank you so much.
On all alternate Saturdays we are doing. You are welcome, sir.
Very well done. Very well done. I think you should keep it up, and I think even your students will enjoy it, because they will have a revision and get imagine themselves as a group, and they will stay together and they will discuss with each other. This is the things. God bless all of you. Thank you so much.
Paul,
Thank you, sir.
KMC, since when?
Paul.
You were in which year?
I finished in 1993 my MD. I joined DA in around 1990, around 89 to 91. I did my DA. Then 6 months I discontinued. Then I joined MD again. Finished 93. I came to Saudi Arabia in 1995. So from that time I'm here.
Paul, Bilal was one of our best postgraduates. In the sense that you can't believe the knowledge what he has accumulated now and the way he gives anesthesia. I think we should hear from him with all his best anesthesia what he is doing there. I'm really proud of this fellow.
No, this is your blessing, sir. Your Ashirwad, sir. Nothing. You are nothing at all there.
Do you remember me, Bilal?
This is my Venkatgiri. Yes.
This is what we wanted. Where you went, Venkatgiri?
I am here only.
How are you?
Bilal, you made me to.
Mr. Bilal, can you show yourself?
He was making.
You switch on your video.
I changed to my night dress. I will switch on.
Okay.
I changed to my night dress. That's why I was putting it off.
Okay.
So it is a pleasure to see Venkatgiri also around. It's a very nice thing. If Madhu had joined us, it would have been better. We are all classmates rather than myself, Madhusudan, Venkatgiri, all in the same group. Dr. Gurudat, then Nandakumar, Sagar, all these were in a group, it was really way back in the 1990s.
I was also in Mangalore that time in Congenital hospital, but it was 92 to 95. And Koshi, T.A. Koshi was my professor and is also mentor. He is no more now.
Yeah, God bless his soul. We are really lost.
You have a very good museum in KMC, right?
Yes, we had a very nice, very nice time.
It's so nice to see everybody along with this educational program.
Yeah, right.
Yeah, it's like meeting again, only sir, like going back to the days. Hopefully we keep meeting like this. So every Saturday I am on now. I will be switching on to the ISA Kerala group.
It's every first and third Saturday of every month.
If you send your number, can you send your number or you tell me your number? We will send you the link. I'm the person will be sending you.
I will
forward the number to you.
I will put in the KMC group.
Yeah.
Okay. KMC 2 groups, both groups I will put. I was not putting KMC group so far. I will put in that group. So everybody.
Thank you, Venkatgiri. Thank you, Venkatgiri.
KMC group.
So see all of you. Have a nice time. Have a nice weekend. Go and enjoy. My week starts tomorrow.
What is the time there now?
Now it's around 6:45, 7 o'clock.
Yeah.
2.5 hours.
So you a week has started, right?
Yeah, tomorrow my week starts. So weekend to you guys and my day starts tomorrow. Okay. Tomorrow we have a new batch of residents coming. So we have a like a boot camp for them. The first day we teach them, train them what to do, how to expect in anesthesia. So the whole day will be with them. So it's a boot camp for them.
You finish your food. Akil Kalas, Akil.
Akil, no, not at Kalas. I have to go to Akil. Okay. Thank you. So you are in Saudi Arabia. That looks like good. Okay, sir. Mali, sir. Nice meeting you, sir. God bless you. God bless you, sir. God bless you. You are busy in the war.
Allah bless you. Allah bless you.
You are busy in the war. Okay,
no,
sir.
I just came for a case. I started the
Oh,
case and I'm sitting here. I did not want to miss it.
No, it was nice. It was really very, very nice. I didn't miss 1 minute, but in between the reception was not very good. I think a lot of people were listening to us, so it was a little disturbed. But anyhow, it was very nice. Thank you. And the PGs are very smart. Both of them were excellent. Very good.
And Paul, I want to wish all the postgraduates good luck for the exams.
All the best. Yeah, all the best for their exams. Hopefully,
I
they
will
come out
convey
with
the
flying
regards
colors.
in the PG group. Now, almost all of them, most of them have left. Only 30 is remaining. I will definitely convey that in the PG group. We have the update group around 1,000 are there in that. 5 groups are there. I will definitely convey. And thank you for the excellent presentation.
It was really nice. It was really nice. Really, sir, put it very simply, very simply.
And
also,
also,
nice. I like the word he put in the last. Said cancellation should not be an option.
These 2 PGs, it was an excellent presentation. And in between, I called madam and asked, is it the first time? Like, how many they have presented? She said it is the first time. So, big applause to them, and also their mentor, Dr. Samsad.
They did excellent.
Thank you all the PGs for coming late. And Dr. Rajesh, you have any announcement regarding the next one?
No, we have not confirmed the next session. It will be on 5th March. The faculty has to confirm. Hope I will get the news by tomorrow. Confirmation by tomorrow. So we'll be putting it in by next week. It will be in the 5th of March.
Okay,
the same
inshallah,
time.
next week.
5th March, madam. 5th March, madam.
Yeah.
Good night.
Good night.
Okay, nice meeting you all, guys. Thank you so much. Thank you so much for accommodating me. I took most of your time. Sorry about that.
No,
not at all.
Thank
Please
you.
visit Kerala also.
Thank you.
Sure. My niece is married in Kerala. She's in Kannur. So I'm a Keralite half of it.
That is a place you said it is a primitive rural area. You said Sagar, that is a rural area.
No,
most developed area in Kannur.
No, I'm not talking about.
He's working in a Kannur, like one of the biggest multi-specialty hospital.
I didn't talk about Sagar. I was talking about, you see, when you are outside, yes, you may escape by giving spinal. Nothing to do with Sagar. I know it. Mashallah.
And I too worked in Kannur. Where exactly you are saying that your sister's place?
Payangadi. My niece.
Payangadi. Yeah, it is just to.
Her husband is Dr. Amjad, a nephrologist there. Okay. Dr. Amjad, his name is a nephrologist. Okay. So I used to visit her last year. When I came last time to India, I visited her. Hopefully to visit again.
Yeah. Please call us when you come over there. Right?
Sure. One of the best.
In Pariyaram Medical College, which is very near to that, almost 6 years.
Yeah. I think he's also there. My niece's husband is also, and niece also is working in that Pariyar Medical College. I think both of them are working. Okay. Oh, sir, nice. Have a nice time. Please go and enjoy your night. Bye bye. See you all.
Good night.